evening, doctors, and thank you for being here this evening. My name is Muhammad Alim, and I am working with Fresenius Kabi. Today, I am pleased to welcome Dr. Manoj Kumar, a very special guest from Gaya. And Dr. Manoj Kumar is an associate professor in Department of Anaesthesiology at Anugrah Narayan Magad Medical College and Hospital. Dr. Manoj Kumar is holding a position in governing council members of Indian Society of Anaesthesiology. And Dr. Manoj Kumar is also an ex-secretary of ISA for the state of Bihar and Jharkhand. With this, I request you to help me in welcoming Dr. Manoj Kumar. Dr. Manoj Kumar, over to you. Thank you.
Thank you, sir. Uh, Very warm welcome, all of you. This is the first time virtual webinar of the IS Indian Society of Anaesthesiology is June. With this regarding, I invite our guest of honor, Dr. Naveen Malhotra, sir, and Dr. Murlidhar Joshi, sir, our chief guest, as a chief guest. And we have six speakers today from East Zone and also from two guest speakers from Northeast Zone. So I request Dr. Murlidhar Joshi, sir, kindly speak for 5 minutes. Before that, I read out a short introduction of Dr. Murlidhar Joshi, our chief guest. Dr. Murlidhar Joshi is a president of the Indian Society of Anaesthesiology, National Headquarters, and director of the Pain Management Center for the Virnich Hospital, Hyderabad, Telangana, and is considered to be one of the pioneer of the pain management in Asia. He was treasurer of Indian Society of Anaesthesiology since from 2011 to 2015, and honorary secretary of the Indian Society for the Study of Pain, that is ISSP. He is a member of the WFSA Pain Relief Committee and a council member of the WFSA. So I request our chief guest, Dr. Murlidhar Joshi. Kindly, sir.
Thank you, Dr. Manoj, for the kind introduction. Good evening, everyone, and greetings from ISA National Headquarters. We're happy to join the mega event from the ISA East Zone team members. Proud to see all of them after a long time. This pandemic has made all of us stay at home and maybe stay at workplace rather than moving here and there to meet our friends and all. And I'm glad to meet all of you and all. Of course, the pandemic has literally shaken the whole foundation of the overall economy and lifestyle across the world. And it's coming to India, definitely it has made a difference. And a lot of institutions are closed, or probably they're not able to do full scale work. Many places, even the non-COVID work has come down, and probably some places, at least pockets like Hyderabad and all, they're coming out of the COVID pandemic. So much so, like 50% of the hospital beds are vacant for the COVID patients, which is a good sign. And in this regard, in fact, we have stopped taking the COVID cases. We're taking only non-COVID work. That itself speaks that we probably are in the course to recovery. Probably we started a bit early, probably sometime in February. So it took about 5 months for us to settle down. Maybe just the states have started maybe April, May. They may take another 1 or 2 months to settle down. And you definitely have very good, fantastic scientific program with speakers like and Dr. Prithvish, Dr. Ritesh Roy, Dr. Gautam Zaha, Dr. Ajit Kumar, Dr. Rakesh Shah, and then definitely the kind of topic which are chosen for this today's event happens to be fantastic. And I know it's going to be a great evening for all of you. And without wasting much time, I would like to say once again, I would like to remind you one more thing. ISA is as old as India because both were formed in 1947. Recently, we celebrated our 74th Independence Day. So that means ISA is getting in the mode of Platinum Jubilee celebrations. So I request ISA East Zone to prepare accordingly. We'll have to celebrate a Platinum Jubilee celebration in the coming few months. And it's going to be a mega event across the country. and wait for communication from the ISA headquarters when to kick off and all. And we are also lining up a lot of programs and maybe circon virtual conference. A lot of things are happening. Once again, we wish you all the best and take care of yourself because a lot of our own doctors are getting affected. A lot of corona warriors are getting affected, and please make sure that everything goes fine. Take care of yourself because family will be waiting for you. With you this word, I would like to say long live Jai Hind. All the best for the event. Over to you, Manoj.
Thank you very much, our President, Dr. Murlidhar Joshi, sir, for you are providing from ICA National Headquarters for all the things for COVID, like face mask, face shield, and the PPE kit. So, and also organized lots of webinar regarding COVID-19, and also for uh, some committee for COVID-19. So thank you very much, sir, for coming. And I would like to request our guest of honor, Dr. Naveen Malhotra, sir, who is MD, DNB, and FIPM, FICA, and FIAPM. He is our Honorary Secretary of the Indian Society of Anaesthesiologists, National Headquarter, and Professor Anaesthesiology, and in charge pain management at PGI Rohtak, Haryana, India. Area of interest chronic pain management. He received ISA Bhopal Award for academic excellence in 2015, and he also received CPR Young Anaesthesiology National Award in 2015. But he has so many publications, 162, and presentation 310. Original work submentor tracheal and retromolar intubation. So I request our guest of honor and dynamic honorary secretary of the ISA National Headquarters, Dr. Naveen Malhotra, sir. Sir, please.
I'm really sorry, respected Dr. Murlidhar Joshi, President, sir, and Dr. Saket Sen Gupta and Dr. Manoj. I'm really sorry for this technical thing. I thought that I am very tech savvy, but this took slightly a longer time and really kept you waiting. Heartiest congratulations to ISA East Zone, and very happy as the National Secretary. My President is also very happy that all the state branches of the East Zone have come together, may it be the Bhubaneswar city or the Meghalaya branch or the Bihar and Jharkhand branch or the West Bengal branch. Absolutely fine that they all are together and working together for an academic event. My president and our president has very rightly said that we have to continue the academic activities. These are the virtual activities, online activities. We have to continue them, and the show must go on under the banner of Indian Society of Anaesthesiologists, our parent body. And I'm very happy to share with you that ISA National has decided that we shall be promoting and supporting these online academic activities by providing by holding virtual conferences and virtual CMEs. Like we used to do ISA sponsored national CMEs and ISA sponsored PG assemblies. So the governing council has taken a decision that we will support and partially fund such activities, and I shall be sharing soon the details with all the state branches for carrying out online academic activities under the banner of ISA, may it be the CMEs, 1 hall, 2 hall, 1 day, 2 day, or virtual state conferences. And the way you have all united together for this particular event, get prepared, as our president has said, for the Platinum Jubilee celebrations of ISA National all across the country. Start from your history, how your state bodies were formed, how your city bodies were formed, how your zonal bodies were formed, and how you progressed, and the way forward. Future, what the future beholds for us. Everybody knows COVID is going to stay here for long, and we have to start living with it. But as Sir has also said, we have to be very, very cautious. There are some pockets in India where the cases are contained, but there are certain pockets where there is very, very severe and steep surge of patients. And as a doctor who is actively working in COVID areas, it really hurts when you see so many patients coming in a single day. Also, it hurts more when you see doctors also getting admitted in ICUs and HDUs. And it is more painful when one of your own colleagues whom you were working 2 days ago is also admitted in SDU and ICU. So please take care of yourself. Do your duties very religiously, but work safely and stay healthy. Your health is important not only for the patients, but for your family members also. So take all due precautions. It is known to everybody that anesthesiologists are holding the forefront and the fort in this COVID pandemic. Whether it is COVID ICU or COVID HDUs, 60 to 70% of the doctors who are working in these high-risk areas are anesthesiologists. In all surgeries, whether it is COVID or non-COVID, anesthesiologists are there. And the other fields also, whether it is pain management or other fields, they are actively doing their role. So I request all of you, just prepare some documentation also, prepare some data also, so that we can project it to the authorities. It is an old dictum: if it is not written, it was never done. So we have to project to the authorities, to the government, to the media, print and electronic, and to the public, the human services done by the anesthesiologist in this pandemic. So in today's National Task Force of Clinical Coordinators meeting of ISA, we discussed that we will soon have a form also, where no need to mention your hospital details, but tell how many ICU beds are there, how many SDU beds are there, and out of those, how many are looked by the anesthesiologist and how many are by the other specialists. So until unless we have got a concrete data, absolute figures, we will be more stronger to project it to the government as well as other authorities. I am really thankful and convey my best wishes to the excellent speakers, professional speakers, star speakers, Dr. Saket Sen Gupta, my dear friend, Dr. Ritesh Roy, Dr. Ajit Kumar, respected Dr. Prithvish Bhattacharya, our old GC member, Dr. Gautam Saha, and Dr. Rakesh Shah. So I am very, very happy for Dr. Manoj Kumar also, my governing council member, who has taken this lead and initiative to organize this event under the banner of ISA East Zone, as well as other state branches, coordinating with them. I am really happy for you, Dr. Manoj. Heartiest congratulations. And I'm very sure that more than 300 delegates are eager to listen to the academic deliberations. Thank you very much. I'm again sorry with folded hands for the technical glitch and keeping you waiting. Thank you very much. Long live ISA. Jai Hind. Thank you.
Thank you very much, sir. Naveen, sir, our dynamic honorary secretary of the Indian Society of Anaesthesiology National Headquarters, and President and Secretary, actually ISA National Governing Council provided very good, very useful things for us across all part of the India, like National COVID Task Force, and lots of webinar and face mask, face shield, which was already provided. I am very thankful for all of you, and best of luck for Platinum Jubilee, sir. We are of course celebrating, sir, our Platinum Jubilee celebration. Thank you very much, sir, for coming. Thanks, and I also call you very soon, sir, for this virtual platform, sir. Thank you very much, sir. Thanks for coming.
Take care. All the
Both
best.
President and Secretary, sir.
Thank you. Thank you,
sir.
Manoj.
Thank you. Thank you.
Okay.
So I would like to call Dr. Saket Sen Gupta, Professor at Apollo Hospital Education and Research Foundation, and Senior Consultant at the Department of Anaesthesiology, Perioperative Medicine and Pain at Apollo Ganges Hospital, Kolkata. He is dynamic speaker, not in the Eastern Zone. He is dynamic speaker in all over the India as well as internationally. So I put name Buddha of the East Zone. So I request Dr. Saket Sen Gupta, kindly proceed.
I will like to add on, with your due permission, Dr. Manoj, one more thing.
Sir,
He is the incoming editor-in-chief of Eastern Supplement of ISA. So,
Okay, thank you.
as decided by your GBM a few last year, and ISA has also decided that we will be soon starting. We have started with the zonal supplements under the banner of ISA IJA, and Northern was launched on 15th. So the deadline for Dr. Saket Sen Gupta is October. My best wishes to you and your team. I'll get back to you in due course of time. Heartiest congratulations.
Thank you, sir. Thank you.
All right.
Yes. Yeah.
Thank you very much, Dr. Manoj, for those kind words, and thank you, Dr. Naveen, thank you, Dr. Murli, for gracing this occasion. And it's a brilliant idea that was brought forward by Manoj, and I think I thank also Fresenius for taking all the effort to bring it together and spreading the word as well. And also HCP Forum for taking care of the back end. Sorry for the initial glitches. I think we'll only get better with time. So I will just take 20 minutes of your time to talk about this. Is something most of you would be knowing about safe anesthesia practice in context of the COVID-19 pandemic. As anesthesiologists, we know what safe anesthesia practices are. I need not tell you. You are always taking care of your patients, taking care of their oxygenation, taking care of their hemodynamics, taking care of their ventilation, and it's as per as the WHO surgical safety checklist. It's that. Yeah. Okay, it's just that in the current normal, there is something that is going to be changed. And what is this? What is going to change? The perspectives are changing. Initially, I think all of us were bothered about the quality and safety of the patients that we were anesthetizing. In the today and age, in this modern current pandemic scenario, you are also taking care of your own quality and safety and your colleagues and staff around you. This is what is the current normal, I think. Okay, the planning and preparation is your planning and preparation is your workforce, the workspace, and how I work differently by what I do. Workspace is is infection control, workforce. So the workspace, I'll just take you through what has been, what people have talked about is essentially the high touch surfaces, and it's trying to figure out that you're not infecting, or those areas are not getting infected, and then they also not become the source of infection. The rest of it is about whatever happens also outside the OR, how you're managing the space, how you're managing the distance between two people. The fundamental thing that you need to remember is how much the spread is person to person, respiratory droplets, and it is that bug that then hits the mucous membranes, and I think this everybody knows. So what many people had at times earlier said about airborne, but this long range airborne transmission is not yet been clearly documented, and the other modes of transmission is also there. For us in the front line or in the operating room, in the intensive care, in the A&E, or wherever you're trying to take control on the airway, for us is the airborne precautions, and here it is the aerosol generating procedures that are performed, wherein you take care of the airborne things other than the fact that you're doing your diligent hand washing, etc., not touching your files. Because here you are knowing that these dry droplets can be suspended in the air, and then they can reach your mucous membrane through your eyes, ears, nose, etc. To me, what bothers are intubation, and possibly even more than intubation is extubation. The other thing that really bothers me is bag mask ventilation. And a positive pressure ventilation bag mask leaks around the mask, and that is where you can really get the viruses around you. There are other things which I think like a non-invasive ventilation, ventilation through a laryngeal mask or a supraglottic airway suctioning bronchoscopy is there. But to me, intubation, more than intubation, also is possibly extubation. So what has been recommended is that where do you take care of these procedures? Many people have said that the best place to take care of this is in an airborne infection isolation room, which is nothing but creating a negative pressure room. And the negative pressure rooms looks like this, where the air entry in cubic feet per minute is little lower than the exit through the negative pressure in terms of cubic feet per minute. And you have an ante-room so that the rest of the environment is separated from the isolation room. You can create it with engineering help in your normal operating room. If you cannot, and if you still have positive pressure with a laminar flow, I think that is good enough. A room which has a positive pressure with a laminar flow of at least 15 or more changes per hour, you will figure out that 99% of the airborne pathogens are removed within 18 minutes. There has been an issue as to who can be inside the room while this procedure is happening. When should the surgeons get in? I think as long as people are wearing the appropriate PPEs like an N95 mask, face shield, eye cover, they can be there even when this procedure is happening. Am I shooting through my hips? It is actually not. If you look through this chart which was given in the CDC, you will figure out this is on the left column, the number of changes that are air changes that are happening per hour. In our hospital, we have an air change of around 20. So you will find that in 99% efficiency is reached within 14 minutes and 99.9% is reached within 21 minutes. So what we say is anybody can come in after 20 minutes if you wish to, or if you have an N95, etc., you can get into the room over there. So this entire thing about the mindset about negative pressure, I think became a lot of issue. But if you have positive pressure, laminar flow, and if your HVAC system has HEPA filters about the flow of air that gets back into your operating room, I think you are doing fine. There are areas where you may not have positive pressure and laminar flow. Even in standalone units with an air conditioner or with a window air conditioner, there are ways by which you can create a negative pressure. It's by kind of, which is a crude system, by attaching a kind of an exhaust into that room, wherein and ensuring from that negative pressure that the circulating air is sucked out. There has also been issues about if you can open windows, closing the air conditioner for the time being till the aerosol generation is over, and then once you wait for those 15-20 minutes or blow air through fans, etc., blow the air out and then close the windows and start the AC. So you have to kind of figure out what suits you best in your environment. Workspace, it's a lot about surface contamination prevention, and you can cover your anesthesia machine. I'll just show you some pictures. This is how our operating room looks like. Everything, the anesthesia machine is covered, the monitors are covered, and if you can't even do that, you can possibly touch the high touch areas. After each patient that goes out, you wipe it with alcohol swipes or some disinfectant swipes that work appropriately for in the virus. There are certain things that happen during surgery which should bother you, and things like if it's a bronchoscopy or an endoscopic procedure which is happening, be bothered about it. If there is a tracheostomy that is happening, be bothered about it. And even high-speed drilling like an orthopedic saw or a sternotomy happening, remember, there is this potential of generation of aerosol. So you be on your guard. I'm sure all of you are on your guard, but be on your guard when this is happening more. I think I talked about this, intubation, extubation. Be bothered about extubation, please. Suctioning, if you can use closed suctioning, ideal. And non-invasive ventilation, if possible, avoid. If not possible, ensure that there is a good mask seal and the generating pressures are low. I think CPR will not deal with it. I think most societies, including the Indian Society and the Indian Council of Resuscitation Research, has come out with it, and you should just follow that. So there is no harm point in delving on this right now. So can we confine the aerosol that is generated? People have thought about it. People have talked in the last 4 to 5 months already. talking for these things and against these things. I think the jury is still out. If you're using it, be careful. Like if you use anything in the world, be careful that you know how to dispose it, how to handle it after the thing is there. Whether you are covering it with transparent plastic sheets, or you are with plastic covers, or with and then intubating, or with an aerosol box. We have been fortunate in having all of this. But what I would just suggest here is, if you see these pictures were taken in the month of April, before you try it on your patient, I think you should be teaching yourself, and then teaching and training others as to how you can do it. You will be at a loss when you suddenly do it straight on a patient. So you can see, if you have a mannequin, or at least make somebody sleep over there, and then try and do that. Okay, so that's up to you how you are going to handle it and manage it. Aerosol box, video laryngoscopy, intubation, all these can be tried. People have been recommended, and we also have tried this endotracheal tube, which is loaded with a filter. So even if after intubation, if they cough on the tube, at least the filter is there to prevent the aerosol to contaminate the room. Extubation is a very, very vital process. This is something that we recommend, and we do it routinely, is that when you extubate, you have a filter attached to the mask, so that when you're pulling out the tube, the mask goes in, and even if there is slight amount of coughing, this will test your skill, that the person should not be coughing during extubation. But even if they cough, at least you have the filter again, which will prevent contamination of the room. So extubation over a filter. Ensure that there are filters attached to the breathing circuit. We have gone a little overboard in having 3, but at least have 2, that is on the patient end one, and on the machine end, at least at the expiratory end. So you have various types of viral filters. Ensure that the filter you are using is actually a viral filter and just not an HIV filter. But most of the commercially prepared filters will have ability to filter the viral. So how will I then sum up the changes that have occurred in my practice? I am today extremely worried during extubation, and this is something that I try to instill in everybody's head, that intubation is a more controlled environment. The person is anesthetized, is paralyzed, and if you have done your basics right, the intubation should be done well, and the person should not be coughing during intubation. But it is extubation wherein it tests your skill. The person should be awake, breathing well, and when you are bringing out the tube, should not be coughing. So be bothered about extubation. Remember, aerosol generation can happen during that time. But more than your aerosol boxes, more than your plastic sheets, I think what has changed, and the game changer, is whether you have appropriate PPE. Your personal protective equipment is the one that is going to matter at the end. So ensure that you have your proper kind of mask, appropriate mask. See that your FitSil test is adequate. There is no leak. Check it. Know how to do it. Eye protection is extremely important. Face shields, people have realized, are extremely important also. And then these are up to you where you work and in what environment you are working. What is your exposure load? Is then how high up you go up on the PPEs, right? Just ensure that you're also not exhausting the stock of PPE, not donning these things at areas that you don't need to. But when you be aware what you're doing and use your PPE. PPE is going to be the game changer. There is a huge amount of query about what should be done after a COVID-19 patient has, or a positive patient, or any patient who has a suspect who has undergone a surgery. I think there is no specific guidance how to decontaminate. Routine cleaning and disinfection is good enough. And if you want to go a little higher, I think universally accepted is the 1% sodium hypochlorite solutions. And as I've shown in this chart, there are various sites, including the CDC, including the ICMR, which will tell you how to prepare this sodium hypochlorite solution. Or if you have a proprietary solution like Vercon or whatever, you can use it, but know how long is the contact time. Patient transfer is very, very vital. Ensure that everybody is masked. We also kind of think that if there is a highly suspicious or definitely positive, put them on possibly even an N95. If they need to receive oxygen during transport, the lowest possible flow, whoever is taking care should have appropriate PPE. The plan of the ward to OT and OT to ward back has to be done very, very well, and you ensure that during this time there is no other traffic that is happening in that route. How I work differently, pre-evaluative evaluation and assessment. I think all of us by this time, if you feel that there is some suggestion that this could be COVID from the clinical features, from the investigations, then take a huge call along with your surgical colleagues whether you need to operate or not to operate. Unfortunately, the answer to this is no. The test that has been universally done, acknowledged as the most specific, is the NAT RT-PCR, but again, that has its own problems because you have a high negative sense values that you come in, so which is around 25 to 30%. Can you do multiple tests to get down to 100%? You can do a lot of things. You can do HRCT test. You can do the people have tried other things, but the answer to that also, there is no gold standard for a multiple screening and achieving nearly 100% accuracy. I think these are about which test to do when when the person is most infective. Let us not go into this. I think I will just take some time over this. I think this is where again our practices need to change or has changed. I need to now know that exactly what monitoring I am going to use, what drugs I have going to use, what is my airway plan, and who should be there with me in the operating room. I do not want change in personnel and a lot of traffic happening between the operating room and the outside environment. So I would have my plan A things inside the operating room and certain plan B things which are outside the operating room with a person waiting over there to hand me over if the situation so arises. With the PPEs, I think all of us have realized that you cannot speak well and neither can you hear properly. So your communications have to be done previously. Things like with using video laryngoscopes can be helpful, but again, it is up to individual preferences. I think this is again something which is a repetition. Rapid sequence induction intubation, most authorities, most guidelines will tell you to that is essentially to ensure that you are not doing bag mask ventilation. Even if you do bag mask ventilation at 2 grip, low tidal volumes, ensuring less and less of leaks. After that, ensure that you are protecting yourself, you're doing hand hygiene, and during the maintenance, if you need to suction, close suctioning, keep the ventilator on standby if you're disconnecting. This, I don't think much has changed about airway pressures and low tidal volumes. I think this is again where this is where it will test your skill, how well you are letting the person emerge out of anesthesia, not coughing, but breathing well. About regional anesthesia, again, I think it's universal masking. And again, about droplet and contact precautions. People have said that, again, it is not much of a change because in UA, most people would use pencil point needles. It's hand hygiene. This is what we have done about covering the ultrasound machine with plastic transparent sheets. But let me tell you, with this, it becomes at times, if it's a major gross structure like a internal jugular vein or a femoral nerve, you can see it with the plastic sheets. Smaller ones may be very, very difficult. So at times you have to compromise on that. What we essentially do is encase the probe with a plastic sheath, which is also sterile. So these are the small changes that has happened with regional anesthesia. Obstetric, I think not much of a change. Regional anesthesia is the preferred time. After the operation is the patient moves out of the operating room, I think I talked about this initially. I will again talk about it. Is clean and disinfect the high touch surface. People have said that wait for 15-20 minutes. Again, it's so that a fresh set of air is in that operating room when it is positive pressure. What about the future? When do you start? As I think Dr. Murli was saying, that they have already started their non-COVID work in a big way. When do you start is, I think, as he was speaking right at the beginning, have we seen the peak and has the curve flattened and is declining numbers? Remember, we have to also figure out that we have been denying people of their legitimate right for a cure for a long time. Why is it again going back? So you have to give them the chance to be cured. So you have to take a choice. I think here you need to, as an institution, figure out a policy that do you have when your numbers are now possibly 10 or 15 in a day, and when you go back to your previous numbers of say 40 or 50 in a day, do you have enough PPEs for all your staff? Do you have enough beds? Do you have enough staff as well? Some people might be quarantining. One of the things that many people have talked about is that, is there a sufficient OR supply chain which will support you for 30 days in your institution before you think of ramping up? The long-term future, I think, again, starting from your PAC clinic, if you find, and as Dr. Naveen was saying, that it is here to stay, you will have, hopefully the virulence goes down, but there will be people with that. So if you find, again, these clinical features, history suggestive of that, before you do the pre-anesthetic, maybe it is wise to have that person seen by an infection control physician. In the PPEs, again, in the PAC clinic, again, it's appropriate PPE, physical distancing, hand hygiene, mask. I think this is the same. It's a repetition. The way ahead, we have been trying this, not with much success, but with some amount of success, is when we get a call about a pre-anesthetic checkup from a surgical colleague, and they say that this is an appropriate patient which can go in for a video consultation. So we have a telemedicine system for ASAPS 1 and 2. And after that, I think we're still struggling with this as to the security of the system. Is like when your patient or your patient relative needs to communicate the reports of investigations that you have ordered, is there, instead of them coming physically, a safe, secure platform on which this can be exchanged? And I think along with this, there is this huge fear, not only within you, but also in the patient community, as to how they are going to be safe when they come into the operating room. And we have a huge role to play in telling them that they would be safe when this happens. Things that has already changed, at least as far as I am concerned, but I'm sure it will change in a lot of people, is would I start sharing my stethoscope, pens and handsets, phones, and would I at all use it in the operating room? Because then I have this fear of bringing it back home. I think this is a time when all of us can lunge into this electronic medical records, less of things to write, less of things to touch. A huge challenge, I think this Dr. Naveen and Dr. Murli talked about this, is teaching and training. We have to figure out new modalities. We already all have our journal clubs, our PBLD sessions on Google Meet today, and some classes on through this HCP platform. I also think there is a huge part to play about stress and anxiety management. Mental health and all of our health, mental health is going to be an issue. There is huge amount of worry, huge amount of anxiety, stress, and it's here to stay. You cannot deny it. You cannot run away from it. But you need to figure out how to handle it. So take appropriate breaks when you're working. Identify locations where you can go and take those breaks. Your coffee room, tea room, lunch room is possibly not the greatest of places to take a break today. You don't want to have too many people with their masks down, sipping cup of tea and coffee, or having the lunch together with no mask. That's possibly one of the can develop into an hotspot. If you think you're getting too stressed out, please call for help, get help. Don't feel shy, don't feel ashamed, get help. And if you think one of your colleagues need it, please reach out to that person. That will be wonderful. Figure out a way how to remove yourselves from these thoughts when you leave your workplace and come home, and try and take a break from COVID when you come home. One thing that I have tried to follow is that I have kept myself out of newspapers and news channels on TV. There's hardly any positivity coming out from that. I would rather watch BBC Earth or any football match or cricket match if I put on my TV. Social media groups, especially WhatsApp groups, and you will have thousands and thousands. Your building group, your school group, your college group, etc., and too much of COVID things happening around that. If you have
sir.
Yeah, I am done.
Sir.
Last slide.
Sir, 20 minutes left, sir. Over.
Thank you very much, Manoj. So pursue your hobby, and we shall overcome. So what has changed is that not only my patients, but also my colleagues, my staff, I think all of them could be potentially carrying the bug. What can be the way forward, and what is the take home is that, do you have appropriate PPEs? Are we maintaining the right appropriate barrier precautions or infection control precautions? Are we maintaining the distancing that everybody talks about? I think if you just keep this in mind, your patient will stay safe, you will stay safe, and if you stay safe, your family stays safe, your colleagues stay safe, everybody stays safe. Thank you. Thank you very much for a patient hearing.
Thank you. Well done, sir. Very nice deliberation by our learned speaker, Dr. Saket Sen Gupta. So thank you. Lots of questions, but our plan, participant will ask the question in final question answer round. So I request our second speaker, Dr. I would like to call second speaker, Dr. Pritish Bhattacharya. He is professor and head Department of Anesthesia at Nigrim's Hospital, Shillong. So he is also past GC member from North East Zone and the organizing chairman of the coming ISACON at Shillong. So I request Pritish Bhattacharya, sir. He is also my close friend. Sir, please proceed.
Good evening. Good evening, everybody. I really thank Fresenius Kavi for giving this opportunity. First, I would like to say that fluid resuscitation and fluid management in the COVID scenario, for those who have been working with ARDS patients in the ICU, not much has changed. However, there will be minor things about when to expect it, in whom to expect it. So we have the COVID-19 scenario. Well, we are aware that spike proteins have come and they attach to the surface and join the get into the cell and produce the antigens, and then they lead to the next problem of the huge amount of cytokine storm. However, the important thing that is there is that these immunogenic part of this virus, this is binding to the angiotensin converting enzyme 2 receptors. And it is through this that it gains entry. And these are mostly present in the alveolar epithelial type 2 cells. These are the major areas from where it enters. Nearly 83% of all AS2 expressing cells are alveolar epithelial type 2 cells. But They are also present in the heart, kidney, in the endothelium and the gut cells. And you can understand it is because of this that the symptom that you see in COVID patients, they find their expression. Now, these things that are there, the severity is less in most of the patients. Most of them remain asymptomatic. But for that small group that becomes serious, well, they have a very fast moving pace at which the patients deteriorate. So, therefore, we have to be on the lookout to see when they are starting to deteriorate. So, starting initially with a little bit of interstitial pneumonia, and then the rapid development of ARDS or septic shock, and we have the person having hyperferritinemia, hepatic dysfunction, diffuse intravascular coagulation, and they occur very quickly. In the course of a day, the patient was in the morning talking normally, and I was alerting the patient, please cover your face with the mask in the ICU. He was on observation. And then by evening, the patient is on ventilator. So it is important that we have to understand the underlying mechanisms leading from mild to the severe condition as a result of this immune dysfunction and the cytokine dysregulation. And this is going to be necessary for all of us. But even when we say it, if we see that we mentioned earlier the spike proteins, they are binding to the ACE2 receptors, gaining entry, and they are affecting the different organs. Now, cytokine storm, when it occurs, suddenly we have the major problem that occurs, and trying to anticipate it and trying to prevent it at that point of time is the most important step. So we go for serial IL-6, procalcitonin, and ferritin, D-dimer, and try to see where the patient is heading. However, we find that the storm, when it occurs, the ARDS and the shock, they break loose. So we come to that part of the question where the patient is already more or less getting serious. So what do we want to achieve with fluid resuscitation? Now, all patients are not serious at the beginning, but if we are not careful, the ARDS features being common, because the barrier to fluid going from within from the blood vessel to the alveoli is now barrier is very much deficient. So if we go and give fluids quickly, we will suddenly find that the patient's lungs are flooded and he is going on ventilator. If we don't give adequate fluids, he becomes hypovolemic, dehydrated, and then we suddenly find that the creatinine are rising and the patient is becoming a candidate for renal failure. So we have to have daily basal fluid requirements assessed closely. At no other time are our patients demanding that we pay attention to their fluid condition. You see, sometimes I keep telling my residents in the ICU that the patient survives in spite of you. Because when a patient is admitted, did we really check what was his fluid status? Was he already having slight excess fluid? So we follow a practice of using a body composition monitor. We see how much is the patient's pre-existing at the time of admission fluid margin that we have to play around with. If he is dehydrated because he might have been having fever, he might have been simply not taking food, and the dehydration that has been setting it over a period of time may not have been noticed. And then at that point of time, if we don't continue to take care of that, the patient may land into renal failure. So we have to achieve normovolemia and hemodynamic stability all the time. When we have a resuscitation, then we have to see that fluid that we are giving, when to stop that resuscitation. So the fluid balance between the fluid compartments, this is important, the physiology over here. If we think that the alveolar epithelium is now a weak barrier, the hydrostatic pressure rises in the blood vessel and the fluid floods into the alveoli, and then taking it out becomes very difficult because we have to then try to see whether a bit of diuretics are going to be given. This will cause a fall in blood pressure. And one of the common things that whenever a diuretic is used, the junior doctor on duty, he misses that point that every so often patient has to be checked. And when they are checking that patient, if they are not assessing that the fluid being lost is more, the patient goes into hypovolemia. So, and if we use a colloid to draw the water from the alveoli into the blood vessel and then to get it out from the kidney, this watching this fluid status closely, repeatedly is important. And we have to maintain adequate plasma colloid oncotic pressure. If we give excess, it may lead to failure. If we give the crystalloids, it may lead to more flooding. And most important that is going on, the distance from the RBC giving up the oxygen and the tissue and interstitial edema and going into the cell and the mitochondria getting edematous. So then if the mitochondria is edematous, it does not work. If the interstitial edema is high, then the diffusion distance for the oxygen becomes high. So we have to ensure, initially we used to have a very comfortable thing that a patient has ARDS, okay, we are trying to keep the patient a bit dry. But here in COVID-19, the kidney is also at risk of direct injury from the same virus, because that ACE2 receptor is also there in the kidney. And at the same time, if some of the vessels are getting blocked because the endothelium has also been affected, so we don't have that original scenario of an ARDS patient in the ICU. Even if we are making a slight mistake with dehydration, here the kidney is already having a double whammy, triple whammy, that the fluid volume overload or underload. At the same time, the kidney endothelium is damaged, renal endothelium. At the same time, we are having the person not able to tackle that fluid load, and the direct damage to the kidneys are there. So we have to ensure that the oxygen delivery to the tissue cells and cellular metabolism is maintained through avoiding edema and also avoiding dehydration at the same time. So we have to prevent this trauma-induced increased blood coagulability, dehydration, which is worsening it. So these are the things that we have to watch. So there have been several trials and case series, various agents, etc. have been used. But basically, good intensive care practice, as I was telling, is founded on a strong understanding of the physiology and doing the basics well. Repeatedly checking whether my fluid is going out excess, my intravascular volume is following, and because of that, there is a hypotension, and very often the replenishment, the inexperienced or relatively less experienced junior physician on the night shift will forget and miss, and immediately they start an inotrope. And they're forgetting that that also has got a problem. And at the same time, when the viscosity falls, because the colloids have gone out and we have not replaced the colloids, then we have to remember that hemoglobin levels, if they fall too much, viscosity falls, blood pressure falls, and we cannot raise the blood pressure, so we give inotropes. But when we think, we remember that advertisement, Maggie sauce ka aaja, because it was thick viscosity, and therefore the pressure needed to move that blood will be higher and the perfusion pressure will be maintained. But if the hemoglobin level has fallen, if the albumin level has fallen, So all these things, the oncotic pressure has fallen. Then even if we give fluids, the viscosity being low, you will find that the diastolic pressure is low, and generally it's difficult to achieve the pressure. So keeping a watch on the colloid is also important at this point of time. And these, you can understand that we have issues in an ICU with fluids, staffing, resources, ventilation strategies. These are important for saving the patient. But the patient needs fluid management as the cornerstone of intensive care, because ultimately we are giving supportive treatment to this patient. And at the present moment, our guidelines are only evolving. Nothing really new has come up with fluid management, except that we have to pay attention to detail. Dehydration is going to affect both the kidney and the heart and the brain, because it will lead to greater chances of blockage of the blood vessels. At the same time, we are seeing that the patients, you will have to correct the ARDS features at that point of time. Now, during the early stages, we always thought of a negative fluid balance, but here negative fluid balance, we have to remember, has to be tempered by the kidney may be directly affected, the heart may be directly affected, endothelium, and therefore dehydration is not something we can go to any extent. We have to be playing a very fine line. And we can see that in these patients, there is a higher than expected occurrence of acute kidney injury, and therefore we have to have a slightly more liberal fluid strategy, even in an ARDS-like situation. And so the challenge is that patients are presenting at different stages of their illness. So when we are giving fluids in a patient who is spontaneously breathing, he is otherwise slight respiratory distress, we have to be sure that we don't give excess fluids. And with those who are admitted later in the illness, at the same time, because they have had fever and had tachypnea, they have been losing water, and they may be hypovolemic, and we have not realized that, and we let them carry on being hypovolemic and give inotropes at that point of time. So most cases presenting with respiratory symptoms, but GI symptoms such as vomiting and diarrhea are not uncommon, given that the receptors are there in the gut also. And these also lead to dehydration. So all these features have to be taken into consideration. So the history, very quickly, paying attention to the symptom onset, how long, and what was the severity of the diarrhea, of the vomiting, the tachypnea, how much fever. These are going to be important to assess the fluid condition. And we do it with not only the watching the skin turgor and the capillary refill time, etc., but we also use a body composition monitor. It is a very cheap equipment, and we don't need to think about so much accuracy. We have to see that as long as the patient is not overly edematous, the readings in the body composition monitors give us a fairly good idea about what we are having with the patient at the starting point. And a judicious fluid strategy, where we keep giving only after preload responsiveness has been assessed. This is preferable, given that these, as I mentioned, myocardial dysfunction can occur, and early use of vasopressors and inotropes to maintain the blood pressure, but definitely assessing that it is not the hypovolemia that we are correcting with a vasopressor. And so using an echocardiography or using a IVC compressibility, these are very important and to be done regularly. So notwithstanding the difficulties of using an ultrasound equipment on a regular basis, as just now mentioned by Spikot, but we still have to do it because this is very, very crucial. And the equipment is already there in the ICU, and it gives us a very quick idea and response at that time. So we have guidelines, and the core recommendations may keep at the present moment continue to be in parallel with the survival sepsis campaign guidelines. But as I said, no direct evidence exists for patients with COVID-19 and shock. So this relationship, and therefore the indirect evidence from critically ill patients with sepsis as we mentioned in the very beginning, that we have to use a conservative fluid management, but without tissue hypoperfusion, because, and therefore we may initially give 250 to 500 ml crystalloid, but if there is no response to fluid loading, then we discontinue the fluid administration. Important thing is that we have to use the dynamic indices for volume responsiveness to guide the volume administration beyond the initial bolus resuscitation. Now, this will depend on the local resources. So we may use a passive leg raising, fluid challenges with serial stroke volume measurements, variations in systolic pressure and pulse pressure. IVC size, we mentioned using the ultrasound, and or variations in stroke volume in response to changes in intrathoracic. You see, when the IPPV goes on and the venous return is affected, so there is a change. And for a resource challenged area, we do not need to be so exact. If we see the pulse oximeter waveform and it becomes large and small with the different phases of the ventilation, we know that this patient is hypovolemic. In a spontaneously breathing patient, if the changes are large, even with these changes are less, but on a spontaneously breathing patient, it tells us that this patient is hypovolemic. Now, this is the most important component, the dynamic system. We have got, say, an EV1000, so we can have serial stroke volume measurements, and but not every place will have it. And central venous pressure, at least a trend, people tend to throw central venous pressure out, that it is useless when people don't have anything else. A change is gross, and we have to see. We know that the heart can have its different, functional changes. But if the money is not there, the equipment is not there, we have to follow it. And we avoid using starches and gelatins in these patients. So balanced salt solutions are preferred. All of us know, and this is nothing different. So in cases of significant hypotension or shock, standard assessment of fluid responsiveness, cardiac output assessment will continue. And there should be exercise that we don't make the patients too dry in order to try to spare the lungs, because it may lead to renal failure. So this is very, very careful. So repeatedly checking that is important. Responding to a fall in urine output early is important. Very often, my resident will tell me, sir, for 4 hours, for 6 hours, urine output is low. Now, why do we wait? Because by 4 hours, 6 hours, the damage to the tubules has already started. So, as I mentioned in the beginning, assessment of the fluid balance on admission and on the daily basis with calculation of the cumulative fluid balance. Remembering that temperature is going to cause evaporative insensible fluid loss. Say, for every degree centigrade rise in temperature over 24 hours, there will be a 500 ml rule of thumb loss. So if the 2 degrees centigrade rise, then we must remember 1 liter. Even if we are using paracetamol to take down the temperature, if at the end of 6 hours or 4 hours we are finding paracetamol is red, that means the temperature was there and the fluid loss must be incorporated into that. So a combination of clinical judgment, vital signs, and chart records are important. We should not have a cumulative fluid balance of 10, 12 liters, because that means we have not been watching it early. We have failed in our care. So this is something that we must understand, that we cannot allow large fluid changes to occur. So we have to assess the fluid responsiveness, monitor continuously the mean arterial pressure and cardiac output, and fluid responsiveness before and after fluid administration. And we check for the pulse pressure variation and passive leg raising test. Early initiation of vasopressors when hypotension is not the cause. Noradrenaline at a low dose of 0.05 microgram per kg per minute. And if we find that the dose is increasing 0.5 microgram per kg per minute, we give vasopressin. So important to remember that look at the baseline fluid at the time of admission, the body weight also, and a 10% increase from the baseline is an indication that we are going into fluid overload. Start deresuscitation whenever possible early and replace albumin when it is falling. In the beginning, we don't need to give albumin, and consider reducing fluid through dialysis, when ultrafiltration, even in the absence of acute kidney injury, when we are finding that fluid is becoming high and diuretics are failing to achieve the zero fluid balance. So fluid intake from other sources. When the patient is eating normally, we don't need to give maintenance. That is a very important thing and a common mistake. Patient is eating, but we are giving maintenance. So we have, and whatever patient is taking through other sources should be subtracted from the basic maintenance. And remember, there's a fluid stewardship just like antibiotic stewardship. Using dynamic parameters like skin temperature, capillary refilling time, or lactate to assess the fluid responsiveness. Avoid using albumin initially for resuscitation. And this is important, that norepinephrine remains the first choice vasopressor at present. So kidney damages. So in summary, we can say general principles of fluid management continue as in critical care, and it's important to take a concise history and clinically assess the patient at the time of admission and individualize the therapy. We need to administer maintenance. There's no need to administer maintenance fluids in patients who are eating and drinking sufficiently. Again, we forget it's taking something and we don't give maintenance fluids. Sir, patient is taking orally. We have to ensure that is the patient taking the recommended intake needed, and use balanced crystalloids. And this is very, very important. Thank you. We can take questions if you want.
No, sir. After the end of the session, participant will ask the question. So very thankful. Thank you very much, Dr. Pritik Bhattacharya, for nice deliberation and nice presentation with some breakup. So thank you very much, sir. So I introduce our third speaker. Our third speaker of today virtual webinar, Dr. Ritesh Roy, Associate Clinical Director and Head of the Department in the Department of Anesthesia at Care Hospital, Bhubaneswar, and he is visiting professor at High-Tech Medical College and Hospital, Bhubaneswar, and he is also President of the ISA Bhubaneswar. He is my close friend. I request Professor Dr. Ritesh Roy, kindly proceed.
Thank you, Manoj sir, for a kind introduction, and thank you to ISA East Zone, Freshness, for a very good initiative of starting a webinar series during a COVID pandemic where we are not able to have a virtual meeting. So I will be speaking on TIVA during COVID-19 pandemic. So what is TIVA? TIVA is nothing but the use of only intravenous agent to achieve the 3 stages of general anesthesia, that is hypnosis, analgesia, and muscle relaxation. But the oxygen and air are exception. The oxygen and air you can use, but the rest of the inhalational agents you cannot use. Even nitrous oxide you cannot use in a TIVA. So why the TIVA has become so much popular in recent times? Because of the good pharmacokinetics and pharmacodynamic properties of propofol, new synthetic short-acting synthetic opioids which are coming up, new concept in the pharmacokinetic modeling which has led to development of sophisticated PCI systems. And what was lacking in the TIVA, as in inhalational, you have the MAC monitoring or the MAC monitoring which guides you increasing or decreasing the depth of anesthesia, but in TIVA that was lacking. So right now we have got a PEEG monitor. Even we have got a Conox monitor from the Freshness Cabby, which you can used in both inhalational and intravenous anesthesia. So because of these all properties, the TIVA is slowly becoming very popular. And what are the advantage of TIVA? Why we want to use TIVA? This is a very good review article which came this year about the influence of propofol-based TIVA on a perioperative outcome measures. I will request each and all of you to just go through it. So I will request all of you to go through this very good review article which came this year. So what are the advantage of TIVA? If you see, the advantage of TIVA are in almost all the systems of body, starting from central nervous system, where you have reduction in the intracranial pressure and cerebral metabolic rate. So that's why it's very good when you are doing a neurosurgery under TIVA. Also, when you are doing a spine instrumentation where your surgeon wants a neurophysiological monitoring, so you can do the SSP monitoring. And because of the effect on the central nervous system, you have got reduction in the emergence delirium. And as you all know, there is a reduction in the post-operative nausea and vomiting. So you can have your patient, it's very good for ambulatory surgery. You can have the patient discharged on the same day, because this PONV is really very annoying in the post-op period. And what they have seen, that when you are doing a oncological surgery under TIVA, you have got less recurrence, and in older patient, you have got less post-operative delirium on emergence. Even they have seen a reduction in the incidence of chronic pain and a 24 hours reduction in the pain score when you are doing a surgery under TIVA. The most important thing which is going to help us, it's right now it's not proved, because this virus is quite new. The effects of the COVID on the patient body is has not been studied much till now. But what they have is speculation is on the immune system. The propofol has several potential beneficial effects, like free radical scavenger, antioxidant, anti-apoptosis, and anti-inflammatory properties. And these properties of TIVA of propofol are going to help us in COVID-19 pandemic when you are doing the surgery only under TIVA. And they are good effect on the respiratory system. You have got reduced airway reactivity, laryngospasm, improved ciliary function. So the less chance of patient coming out, waking up, more coughing if you are giving an inhalational agent, and more aerosols spread. And in this situation, in this COVID-19 pandemic, the TIVA is, if you are doing a surgery under TIVA, it's going to help you out. So how can you give a TIVA in equipment? It's either a manual infusion system or a TCI regimen. But the manual infusion system, you cannot have a adequate depth if you are doing. But with a TCI pumps, these are pumps, the pharmacokinetic properties are feeded in it by study on the healthy volunteers. And if you are using a TCI pumps, obviously the depth of anesthesia is going to be much better compared to the manual infusion. But if you don't have a TCI, you can go for a manual infusion system. So what is the TCI? TCI is nothing but a use of a pharmacokinetic model combined with a microprocessor controlled infusion pump to achieve a target concentration of drug in a particular compartment of body. And this concept was first suggested by Thimar in 1968. And the key components of TCI system is a user interface where you enter the patient details and the target blood concentration which you want, and a software, PK model validated software, which then controls the target blood concentration of that drug in the body. So the TCI systems are mainly open loop. It means the effect of drug are not measured, unlike with end-tidal gas monitoring which you have in your inhalational agent. This cause so there is an element of awareness if the target blood concentration is less, and they follow a bolus elimination transfer principle. So what is a bolus elimination transfer principle? The PK models which are developed, they are based on a 3-compartment pharmacokinetic model. The first compartment is a V1, that is a central compartment. V2 is a peripheral compartment which has got a good blood supply. V3 is a peripheral compartment with a less blood supply, and then there is a clearance. And effect side is the brain. You can't measure the plasma concentration on the effect side because these are done on a healthy volunteers. So what they measure is the plasma blood concentration in healthy volunteers, and based on that, they have developed the pharmacokinetic models. So what they have studied by using the EEG monitor, how much time the the drug takes from the central compartment to the effect site, that is the brain, to produce a hypnosis, and that time is a key neo time. Okay, this key neo is a key neo time. Now, a loading dose is given to saturate the volume of distribution in V1 to achieve a target blood concentration. Okay, and then the maintenance infusion is maintained depending upon the drug elimination, that is the clearance, that is the K10, and then the transfer of drug between the V2 and V3. So by this, the whole concept of pharmacokinetic model are developed in a TCI system. Now a concept has come, PK/PD modeling. So what is PK? This V1, V2, V3 and clearance are the pharmacokinetics, and the pharmacodynamics is the drug which produces hypnosis at the effect site, that is the brain. So this is a new concept of pharmacokinetic pharmacodynamic modeling, and this has been enabled because right now we have got PEEG monitoring device to see the effect of drug at what time it acts on the brain. So this is a concept of PK/PD modeling. So the models can be developed either based on the plasma concentration, which I have already told, and on the effect side, that is on the brain. The common TCI models, the first model was a Bristol model, which all must have used, where you induce with 1 milligram per kilo, then you follow a 10-8-6 principle of propofol infusion. But right now in the TCI pumps, the model which is mainly followed in adult TCI pumps are the Mars models and the Snyder model for propofol and the Minto model for remifentanil. In pediatric, you have got the Kataria and the Pedofusor TCI models. And the common available pumps are from Fresenius, from LRS, and one of the TCI pumps which you have with the Fresenius is a Injectomat Tiva, which is a IV anesthetic system incorporating the PK model of propofol, remifentanil, and sufentanil, and it depends on both the plasma and the effect site concentration of the pharmacokinetic model. So I have already told the Bristol model, which many people must have used it. And what is the Mars model? Mars model, it typically targets the plasma concentration, but a modified Mars model has come up which targets the effect site, means the brain concentration. And the only disadvantage with the Mars model is it only works on a total body weight. You only entry is the total body weight, nothing else. So there are chances of faster induction with a high bolus leading to slightly hemodynamic compromise. But in a Snyder model, it works with an effect site concentration, that is based on the brain effect, and it has got the age entry, the height entry, and to calculate the lean body mass and the total body weight. So the advantage of Snyder is, because of all these entries, you have got reduced rate of adverse effects, and overall less propofol are used in the Snyder model TCI pumps. And these are the common drugs which are used in TIVA in adults and in almost all patients, starting from propofol to all the narcotics like remifentanil, sufentanil, ketamine, dexmedetomidine. People are starting using lignocaine in TIVA. So these are the drugs. So what are the COVID-19 challenge? The first and most important is the aerosol. It has found that even after using a wearing full PPE, there was a high incidence of COVID-19 symptoms among healthcare workers after tracheal intubation. Okay. Second are the asymptomatic carriers. Third is the false negative preoperative COVID-19 reports. Limited access to testing in some areas, even in India. Emergency surgery, and secondly, the pressure of starting the resumption of elective surgery. So these are the COVID-19 challenge mainly for our anesthesiologists. And what is the anesthesia strategy which we should follow? Regional anesthesia is a preferred if you can do. But if the regional anesthesia is not feasible, you can go for TIVA. And the types of TIVA are with are with intubation or without intubation. If you are going for intubation, then you have to take all the precautionary measures. Okay. Now, what are the merits of TIVA in COVID-19 pandemic? As I told you, rapid recovery and decreased hospital stay. So your patient goes back fast, decreasing exposure to the healthcare worker, to even to himself. reduce contamination of uh, uh, anesthesia drugs, and reduce contamination of OT. So you are safe, your health workers are safe. Reduce airway instrumentation if you are not putting a tube, and reduce aerosol generation, right? Reduce post-operative delirium, cognitive dysfunction, agitation, and PONV. So decrease aerosolization, decrease fomites spread. Early ambulation and discharge of high-risk elderly patients during COVID-19 pandemic. The most important thing is the cytokine storm in COVID-19, which causes all the catastrophic things and ultimately leading to ARDS and multi-organ dysfunction. And eliminational agents are have known to be have a immunosuppressive effect, which can exacerbate cytokine storm leading to ARDS and multi-organ dysfunction. And the propofol, which is used in TIVA, has got a immunomodulating agent. It acts as an immunomodulating agent and can decrease the cytokine storm. These are all speculation. We don't have any review article on this. These are all speculation because of the property of propofol. So I thought, why not talk about the propofol-based TIVA in children? So TIVA can be virtually used in any type of case unless contraindicated. And when to consider propofol-based TIVA in children? This is a good guideline, why to use, when not to use, and what else you should know before using TIVA in children. So the indications are almost same. If you have got a patient who has got a PONV risk, a patient who has got an emergence delirium, who has got an increased airway reactivity, fear of face mask in children, increased ICP, malignant hyperthermia, and muscular dystrophy. And most important are in neurosurgery, surgery where you have got a PONV risk, airway surgery, and where you want a neurophysiological monitoring like in spine instrumentation, and remote location like the MRI suits. Why not to use? A patient who has got a cardiovascular problem, you should not use. If there is shock, if there is an allergy, and if there is a mitochondrial disease because of propofol related infusion syndrome. Okay, so you should be careful in these type of patient where you should not use a propofol based TIVA. And what else should I know? I should have a IV access. Getting a IV access in pediatrics is a tricky thing. Okay, you will have pain on injection, whether you have got a pediatric TCI model or not. You have got an entry reflex IV lines or not. Okay, so and you should be familiar with your manual infusion system, and you should be aware of the altered pharmacokinetics in neonates, infants, and young children, because young children has got a big central compartment, so the induction dose is high, and you have to use a higher maintenance dose initially. And in neonates, because of the immaturity of hepatic enzyme system, you should have a decreased infusion rate. So you should know all these before using a TIVA in a pediatrics. If you have filled up, you can consider either using a propofol based TIVA, and if you have contraindication, you can go for an inhalational based TIVA. And these are the advantages which I have already told why to use TIVA in children. So whether I should use a IV access, if it's mandatory, then you can go for a non-pharmacological or a pharmacological strategy. But if I am not able to put a IV line, by all these means, I can go for a volatile induction.
Doctor,
Yes.
Dr. Ritesh, sir.
Yes,
Kindly
sir.
wind up. You have completed 20 minutes.
I'm sorry, sir. I'm seeing the time. Okay, sir. Sorry. Okay, fine, sir. Okay. So if how should I reduce the propofol injection pain is by using a large proximal vein, I using a IV lidocaine, okay, and it depends on if you have got a TCI pump. Sir, another 5 minutes, I will wind it up. So depending on the pediatric propofol TCI pump, if I have got, the target is to maintain a plasma concentration of 4 to 6, but if I am using an agent, the target concentration is 3 to 4 mics per ml. And these are the models which I have already told, the pedofusor and the Kataria model, and it depends on, but if I don't have the TCI system, I can go for a manual infusion like the Marlin dose scheme and the Stewart dose scheme. This is a Marlin dose scheme and this is a Stewart dose scheme. You can always go through it and you can start using in it. And these are the agents which I can use I can use a remifentanil, I can use a fentanyl, I can use a ketamine, I can use a dexmedetomidine, and so what are the monitoring? The monitoring is a PEG monitoring and the clinical monitoring. If you don't have a PEG monitoring, you can go for a clinical monitoring like the heart rate, the blood pressure, and the movement. So by this way, you can always start using a TIVA in a pediatric patients. Thank you very much. Thank you.
Thank you very much, sir. Thank you, Ritesh
Thank you,
Roy,
sir.
sir, for presenting such a nice subject in a very well manner. Uh, Thank you very much. So I would like
Thank you.
to call our fourth speaker, Dr. Gautam Saha, who is the HOD in the Department of Anesthesia and Critical Care at Bokaro General Hospital. He have organized lots of conference in Bihar, Jharkhand, and presently is organized very nice conference at Bokaro, I say Bihar Jharkhand conference. So thank you very much, sir, for participating as a speaker in this virtual ground. So I request Dr. Gautam Saha to kindly proceed.
Thank you,
Kindly present.
Manoj. Thank you, Manoj. Can you hear me?
Yes, sir.
Thank you, Manoj, for those nice, lovely words. And I've heard three speakers. They're wonderful, wonderful, highly knowledgeable, very entertaining. And now it's my turn. Very good evening to all of you. First of all, I'd like to thank Dr. Manoj, the ISAE zone, and the organizer of the Fresenius Kavi for giving me an opportunity to address this August gathering in the midst of this pandemic. My topic is a bit different. The role of paracetamol in perioperative pain management. This is what I'm going to speak over the next 12 to 15 minutes. Surgery and pain, they are inseparable twins from the times immemorial. And it has always been an endeavor of the perioperative physicians, that's anesthesiologists, to alleviate pain in our patients who come for surgery. Because the patients, whenever they come for surgery, what they fear most is pain. So our prime duty is to alleviate pain because it has got a lot of consequences, as we are going to see over the course of next 10 to 15 minutes. So over the years, many new drugs, new molecules have emerged, and new old molecules have been reformulated to provide more effective pain. And one such molecule is intravenous paracetamol. The paracetamol was discovered almost in the year 1875. It came into clinical practice effectively in 1950s, but intravenous paracetamol came into clinical practice almost a decade back in 2010. So first, let us define what is pain. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But what's wrong with pain? Because what causes pain? If we look at it, we'll come from a common sense because we worked in the operation theater, is incision to the skin and subcutaneous tissue, trauma to deeper tissues, periosteum, and coagulative procedures, endotracheal tubes, chest tubes, nasogastric tubes. Whenever they are manipulated, it causes a certain degree of pain and discomfort to the patient. Post-operative rehabilitation therapy, changing the dressing wounds post-operatively, and urinary retention. These are some of the common causes of pain, but in no way this list is a complete one. Why are we so much concerned about pain? Let us see what does the post-operative pain causes to the patient. It leads to cognitive dysfunction. It leads to coronary ischemia, and in susceptible patient, it may even lead to myocardial infarction. It leads to deep brain thrombosis and pulmonary embolism. Insomnia, pneumonia, it leads to poor wound healing and recovery, and progression of chronic pain increases with intensity of acute post-operative pain. And in children, those who have a bad experience with pain during the childhood surgery have a long-lasting effect on their cognitive function. behavioral changes in children. What are the outcome on relief pain? It leads to delayed recovery, prolonged hospital admission, decreased patient satisfaction in ambulatory setting, peripheral and central sensitization, and long-term chronic pain states, and increased burden on the healthcare system. So what do we do? What are our options, and what are the armamentariums with us to control pain? The commonly used armamentariums which are at our disposal are opioids, non-steroidal anti-inflammatory drugs, paracetamol, regional blocks, and central neuraxial blockade. The opioids, as we know, they act by mimicking the action of endogenous opioids by acting on the opioid receptors in the brain and the spinal cord.
Gautam sir,
Non-steroidal.
Gautam sir,
Yes.
uh,
Can you hear me?
you kindly take your mic near to the mouth. So we are
Okay. Can you hear me now?
okay. Yes.
Can you hear me now?
Yes.
Can you hear me now?
Yeah.
Sorry. What are the options available to control pain? Opioids, they act by mimicking the action of endogenous opioids by acting on the opioid receptors in the brain and spinal cord. Non-steroidal anti-inflammatory drugs, they act by inhibiting cyclooxygenase enzyme, thereby preventing the formation of prostaglandins. Paracetamol. The paracetamol also inhibits prostaglandin H2 synthetase, but there are other recent studies have demonstrated that there are certain other mechanisms by which paracetamol acts, and thereby intravenous paracetamol is so effective in controlling pain, such as activating the descending serotonergic pathway and endocannabinoid enhancement, as we shall see in the later slides. Here we can see that arachidonic acid is converted to prostaglandin H2, and it is the paracetamol, it acts on enzyme prostaglandin H2 synthetase, thereby preventing the formation of prostaglandin H2 and battery of other prostaglandin E2, prostaglandin I2, and thromboxane, thereby inhibiting the pain, development of pain. Endocannabinoid enhancement. In the presence of enzyme fatty acid amide hydrolase, which is found predominantly in the central nervous system, paracetamol is conjugated with arachidonic acid to form an active metabolite called AM404. AM404 has a property that it inhibits the endocannabinoid reuptake from the synaptic cleft, and this explains the relaxation. Can you hear it? Can you hear it? Hello, Manoj. Hello.
Sir.
Hello. Can you hear it?
Sir. Yes, sir.
Acha. AM404 inhibits the cannabinoid reuptake from the synaptic cleft, and this explains relaxation, euphoria, and tranquility reported by many paracetamol users. AM404 appears to be a key player in inhibiting a number of pain pathways, and probably this how it helps in alleviating pain in the patients who are given administered paracetamol. So this is how the endocannabinoid enhancement acts. Serotonergic pathway activation. Serotonergic pathways are part of the descending pain system originating in the brainstem nuclei, hypothalamus, cortex, and interacts with brain afferents in the dorsal horn. It is widely accepted that the activation of the descending serotonergic pathway by paracetamol plays a key role in producing analgesia. In fact, when H3 5-HT3 antagonists are co-administered, like ondansetron and ganacetron, they decrease the efficacy of paracetamol, with further reinstate the fact that paracetamol acts by acting on the serotonergic pathway activation. Why intravenous paracetamol? We have been using paracetamol by oral route, by rectal route, and also by the buccal route. But the rapidity of action is lost because of, and the effective is also lost because of the variability in viability, which changes from 68% to 96%. The availability of IV paracetamol has greatly extended the use of paracetamol in post-operative pain for the control of fever in the ICU setting. Is also the choice of administration when renal rapid analgesia is needed, especially in the post-operative stage. How soon does IV paracetamol act? As we can see, the onset of action takes place within 5 to 10 minutes. The peak effect is obtained in 1 hour, and even the duration of analgesia lasts from 4 to 6 hours. When used as an antipyretic, the action occurs within 30 minutes of administration and the effect lasting for about 6 hours. As we can see from the graph here, the mean we can see when the paracetamol is administered over 2 minutes injection or as a 15 minutes infusion, we can see the peak effect is reached in about 30 minutes and onset of action takes place about 5 minutes and the duration of action lasts for a long time. Whereas when we are using oral paracetamol, the peak action it takes place in about 90 minutes to 1 hour, 90 minutes to 2 hours, and the action also prolongs it for about 6 hours. What is the recommended dose? In adults weighing more than 50 kgs, the dose is 1 gram with a maximum of 4 grams per day. That is the safe limit. In children weighing between 33 kgs to 50 kgs, the recommended dose is 15 milligram per kg with a maximum of 3 grams per day. And in children between 10 to 33 kgs, the dose is 15 milligram per kg with a maximum of 2 grams per day. And full-term newborn infants and toddlers and children weighing less than 10 kg, the dose is 7.5 milligram per kg with a maximum 30 milligram per kg per day. The route of administration is IV with an infusion a bit over for 15 minutes and the maximum duration action between 4 to 6 hours. As we know, we say the paracetamol is a very safe drug. But just like any other drug, when it has got its own share of drawbacks, there are the most common drawback with paracetamol is it can cause hepatotoxicity if the safe dose is exceeded. It usually occurs if the safe dose is exceeded over several days and there's a concomitant deficiency of glutathione, commonly due to malnutrition or enzyme P450 enzyme induction by chronic alcohol intake. Glutathione is an enzyme which helps in converting one of the toxic metabolites of paracetamol to NAPQI, that is N-acetyl P-benzoquine, which because this is the compound which causes hepatic necrosis and leading to hepatic failure. Renal toxicity when used up to 4 grams per day, it is very safe and there is minimal chance of developing renal toxicity. In fact, the National Kidney Foundation has recommended as a non-narcotic of choice in patients with underlying kidney disease. We have all learned from our childhood that aspirin is indicated to trigger asthma in children or even in adults. But recently, a very strong body of evidence have emerged that paracetamol is a causal agent of asthma, and especially in the pediatric age group. So when we are using in the pediatric age group, it's very common. We have to use caution before using this drug. Now, when we are comparing the various type of painkillers or analgesics, we have to study what are the drawbacks of opioid-only analgesia. We know from our MBBS days that the common side effects of opioids are respiratory depression, sedation, post-operative nausea, vomiting, pruritus, urine retention, and constipation. Due to these drawbacks, an effort was initiated for multimodal analgesia. Paracetamol intravenous finds a role as a single agent or as a part of the multimodal analgesia due to its clinical profile. NSAID has also the share of drawbacks, in especially rofecoxib and celecoxib. When they're used, it has been seen they cause hypertension, myocardial infarction, and even stroke has been implicated. It is well known they are associated with nausea, ulceration, anemia, and perforation, and analgesic nephropathy is a well-known complication with the use of NSAIDs. Hypersensitive reaction, urticaria, asthma, and hypertension and shock are also there, and NSAIDs also interfere with fracture healing and bone tension in the orthopedic patients. So now coming after seeing the benefits and advantages of the NSAIDs and opioids, we see where does the paracetamol stands. There is no centrally mediated side effects like sedation, constipation, nausea, vomiting, and respiratory depression. It has got a very quick onset of action.
Gautam sir, only
Yes.
2 minutes left.
Yes.
2 minutes left.
Okay.
Read
There's
completely
no
in 2
single
minutes.
side effect. Good renal and safety, hepatic safety profile. Safe even for breastfed babies. Few contraindicators and drug interactions are there. It's not moving. Hello. Next. I'll come to a few clinical studies. I will end in 2 minutes. Recently, Indian Journal of Clinical Anesthesia recently as published in January-March 2018, they have shown that paracetamol has a better efficacy than tramadol hydrochloride in providing intraoperative and postoperative analgesia when used preemptively with reduced number doses of analgesic and almost no side effects. As we can see from this graph and from this table, the mean VAS score after administering paracetamol is much less than the tramadol group, and even the rescue analgesia required in the paracetamol group was less than the tramadol group. This study shows that opioid sparing effect of paracetamol. IV paracetamol significantly reduced total meperidine consumption and pain intensity score compared with other placebo. IV paracetamol can be effective and safe part of multimodal analgesia postoperative pain management. Same is shown here. On the contrary, it has been shown that NSAID like diclofenac does not improve intraoperative stability or decreases the intraoperative opioid requirement in geriatric patient undergoing intense fixation of subcapital fracture of femur. We conclude that advantage of IV paracetamol is superior pharmacokinetics, superior efficacy to both oral and rectal forms, greater opioid sparing effect when opioid compared to even to NSAIDs. We conclude paracetamol IV is a fast-acting analgesic as effective as morphine, proven opioid sparing effect, well tolerated in all types of patient, ready to use and cost effective. Thank you very much for a patient hearing. I hope I have not exceeded the time.
Thank you very much. Gautam sir, thank you very much.
Thank you, madam.
We have presented role of the paracetamol in perioperative fluid pain management. Very nice topic. So thank you very much, sir.
Thank you, Manoj. Thank you.
So kindly start Princess Kabi video on the COVID.
At these times, nosocomial infections have a new meaning in the coronavirus pandemic. Nosocomial infections are the infections which develop to a previously healthy patient coming to the hospital for other treatment, but gets infected after 48 hours of admittance. This happens because the hospital and ICU settings have pathogens lurking in the atmosphere. These airborne infections can enter directly into the bloodstream of admitted patients through the IV bottle off saline administered to almost every patient. In an ICU or hospital, there are multiple infections in the atmosphere, which through the poor ventilation and close patient vicinity, get transferred into the vein of the patient. Infusion systems are an important part of overall surgical and ICU care. These systems are either open or closed. All open systems or semi-closed systems that are fully not collapsible require an air vent to fully drain into the vein of the patient. Usage of the open systems, like plastic and glass bottles, can increase 54% of mortality rate due to hospital-acquired infections. The chances of contamination in an open system are 10 times higher than closed system, like the collapsible bag. Closed infusion system is superior to open system in providing prevention against hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Introducing the new innovation from the leaders in volume therapy worldwide. FreeFlex DEHP-free, non-PVC environment-friendly solution to infusion therapy. Sterilized at 121 degrees centigrade within secondary wrap, hence no re-sterilization required. It ensures maximum asepsis of the primary bag. FreeFlex bag is made of polyolefin and is water vapor resistant, so no adsorption of drugs on the inner surface of the bag. FreeFlex bag is self-collapsible bag and therefore does not require any air vent. FreeFlex bag has innovative infusion and injection ports, especially designed for safe and easy handling. It has rigid sterile injection and infusion ports. Therefore, force required to pierce is adequate, hence prevents.
Hello. Am I audible? Hello.
Hello. Yes.
Hello.
You are audible. Yes.
Needle stick
Yes.
injury.
Sir, you are
The
audible.
Pulitzer steroid
Okay. Can I start, sir?
have tamper evident
Dr. Manoj.
Yeah.
break off caps with color and arrow indications.
Yes. You can
Membrane
start.
below covers
I-
septic.
first of all,
Disinfection of the membrane is not necessary.
Dr. Manoj, Dr. Muralidhar, sir, and Dr.
Pulitzer
Malhotra, sir,
self-sealing
and
to
Fresenius
prevent leakage
technical
even
tools, and
after
the
multiple
SCP
like
forum, the technical support.
Freeflex has an excellent
My slide
drug
is not-
compatibility.
I request Dr. Ajit Kumar, our fifth speaker, who is additional professor at Department of Anaesthesiology at AIMS Patna. He is very
Yeah.
learned speaker in our history. So I request Dr. Ajit Kumar, can you proceed?
Okay, sir. Thank you, sir. Thank you, Dr. Manoj, sir, for introducing me.
Okay.
And I will start my topic. And the topic is rapid sequence induction intubation in COVID's time. So, when you are going to decide whether patient need intubation, there are several questions come to our minds. The questions are: can the patient maintain an airway? Can the patient able to protect this airway? Is the patient is appropriately ventilating? Is the patient is appropriately oxygenating? Is the patient condition is going to deteriorate in the next few hours? Or is the scene is safe for both patient as well as caregiver? So, the learning objective of this session will be you will able to know the 7 P of RSI. We will discuss the historical rationale of pre-medication or pre-treatment, or now it is called pre-intubation optimization, and we will able to understand the rationale of use of one induction agent over another, and you will able to identify the contraindication to succinylcholine administration and how to manage the patient who are not the candidates. So, what is RSI? Basically, RSI is the virtual near simultaneous administration of neuromuscular blocking agents and sedative hypnotic drugs in order to facilitate oral intubation of a patient with the least likelihood of trauma, aspiration, hypoxia, and the other physiological complications. So what we will do? We will induce the patient simultaneously with sedative hypnotic and rapid acting paralytic agent, usually use succinylcholine or rocuroniums. So what is our goal? Goal is to avoid assisted ventilation in the patient who has elevated risk of aspiration, like we as unfasted patient with gastric outlet syndrome, morbid obese, patient pregnancy, and so on, etc. So the question arises, why we use RSI, why not conventional? So various study has supported this, that by using RSI, the success rate is good and with least attempt, and it will take shorter time than the conventional one. So
Dr. Ajit,
yes.
Dr. Ajit, kindly turn on your video.
Video, I'm not visual.
No, you are not visible.
Okay. Now I turn my video.
Okay, thank you.
Okay, sir. Thank you, sir. So one study that has conducted US Air medical program, they have compared the RSI with blind nasal tracheal intubations, and they found that they have success rate of 84 to 100% as compared to 72% success in medical cases and 66.7% success rate in trauma patients. And it will minimize the adverse physiological effect which occur during the airway manipulations. Now, these are some examples of RSI indications, that is traumatic brain injury, severe thoracic trauma, clinical condition accepted which deteriorated, and unconsciousness patient or acute loss of consciousness for potential for the actual airway compromise. Now, come to the 7 P's of the RSI, rapid sequence indication, and the 8 P which will be discussed later on, that is protected intubation in COVID times. So P7 P's are preparations, pre-oxygenation, pre-treatment and inductions, paralysis, placement of the tube, proof of placements, and post-intubation managements. So start with the preparation. preparation, basically you have to assess the patient airway, you have to assess the airway for difficult airway, you have to plan for airway management, including your backup plans. We have to put IV, we have to look for IVSS, we have to attach the monitor and other instruments, and we have to assemble all the equipment necessary for intubations, the post-intubation medications, and even you have to look for surgical airway just in case you required. Now, pre-oxygenation. Pre-oxygenation is very important, and the goal of pre-oxygenation that it will increase your O2 reservoir, it will maximize time for intubations, it will prevent need for further bag and mask ventilations, and there are various methods to pre-oxygenate the patients. Ideally, a normal patient will give 3 to 5 minutes of 100% oxygen with face mask, or 4 to 8 vital capacity breathe with 100% oxygen. It has been said that if you give pre-oxygenation with 100% of oxygen for 3 minutes, your oxygen saturation will be acceptable for the next 8 minutes. And if you get 4 vital capacity, your acceptable oxygen saturation will be 6 minutes. So pre-oxygenation increases the safety of RSI and duration of apnea phase and the time of dissociation. And this pre-oxygenation is very complicated by very comorbidity like body habitus, agitation of the patient, cooperation, availability of the equipment to deliver 100% oxygen. So in this picture, it is showing that how much time the apnea and the desaturation to 90% the normal people takes, the normal 70 kg adults. You see here the time to desaturate to 90%, it will take around 8 minutes in fully pre-oxygenated patient. Similarly, in obese patient, you will see it will take less than 3 minutes. Similarly, in pregnancy patient, time of desaturation of 90% will be less than 3 minutes. In normal children, it is 10 kg child, it is 4 to 5 seconds, and in moderately severe patient, it will take less than 5 minutes. Sorry. So pre-oxygenation is very important. Now come to the pre-treatments. Pre-treatments, basically, previously the management of difficult air is focused on the anatomical difficulty of laryngoscopy and intubation. But now the great emphasis has been given to the physiological changes during airway intubation and airway manipulation. So the goal of pre-treatment is to mitigate these adverse physiological reaction changes. And you have to particularly important, you have to give in to patients who are in shock or who are hypoxic. It is also called pre-intubation optimizations. So the goal of pre-treatment is to mitigate the adverse physiological reaction to intubation, that is, it will decrease the sympathetic pressure response, decrease the chances of bronchospasm, decreases the chances of increased intracranial pressures and the muscles folliculations. It basically will start 2 to 3 minutes prior to induction, and it is remember as previously as a load, mnemonic load. So load refer for lidocaine, opioid, atropine, and defasciculating agents. So start with the lidocaine. Dose will be 1.5 milligram per kg IV. It will prevent the rise of intracranial pressure by preventing cough, blunting the pressure response, and it may reduce the reactive bronchospasm in asthma. But the role on preventively increase ICP is controversial. Now, opioid, obviously we have only fentanyl, short-acting opioid fentanyl is to give 3 microgram per kg. It provides analgesia also. It reduces the pressure responses, limit ICP, and it is more effective than lidocaine. Atropine, basically atropine dose is 0.02 milligram per kg body weight. It is basically used to prevent bradycardia caused by airway manipulation, and dose of succinylcholine in especially in pediatric patients, which causes bradycardia. So atropine can be used. Now the defasculating agents. Now this when you use succinylcholine, there is, and when fasciculation again, it leads to muscle pains, increased intragastric pressure, which leads to emesis, increased ICP prevention. So to prevent this, what generally conventionally leave 1/10 of the non-deploying nasal muscle membrane. But nowadays succinylcholine, we are not using regularly succinylcholine. We have shifted to rocuronium. So this is not required now. So induction agent, we have ideal agent given is just immediately before the paralyzing agents, or with simultaneously we can give. Ideal induction agent will have property of rapid loss of consciousness, should give analgesia, amnesia, and you should have a stable hemodynamics. So methyl fentanyl agent is propofol means post-intubation care. In post-intubation care, we secure their way, give post-operative analgesia and sedation for proper ventilations. So options generally will give propofol infusion, will give bolus fentanyl or midazolam, or combination of fentanyl and midazolam infusions. Now come to the last one is 8th, that is protected. What is RSI? Protected RSI. What is protected RSI as compared to a standard RSI? So general guidelines are they have given emphasis on the provider safety. So what they tell, you rapidly sequeling the airway, but you slow down to prepare yourself, your team, your patient with strict adhere to PPE, donning the thing. With these safety measures, we will not find of how to prepare, how to pre-accident, and the other sequences of rapid inductions. So the evidence of this modification is not great. It is evidence C, or you can see a by experience. So that you need to think about the PP might affect performance, and you have to come up with the solutions and some modifications. That is very important, and proper is the there are
So network issue. So I would like to call next speaker. After that, I would call Dr. Ji. Hello. Sorry for inconvenience. For network issue, I would like to call Dr. Rakesh Nangotham, who is the associate professor at Department of the Anesthesia at Jain Institute of Medical Science from Port Imphal East. So he's very dynamic person, and his topic is hospital-acquired infection and method for its prevention. So I would like to call Dr. Rakesh. Can you proceed?
Thank you, sir, for a wonderful introduction. First of all, I'm thankful to the ISA headquarters Honorary Secretary Professor Navin Malhotra and President-elect Molidra sir, and Freshness Kavi for giving a chance for to present. And after completing all the anesthetic perioperative management in a COVID care, starting from anesthesia issue to intubation, TBR, analgesic, and RSI, I will take you away from the anesthesia, and I will take you to the hospital-acquired infections. And I hope I will take you to the smooth sail, and I will try my best level to finish my slide in the stipulated time. So hospital-acquired infection is an infection acquired during the hospital care, which are not present or incubating at an admissions. Hospital-acquired infection and nosocomial infections and healthcare-associated infections nowadays are interchangeably used. So should not be confused much. And is an infection acquired in hospital by a patient who was admitted for a reasons other than that infection. So these include infection acquired in hospitals, but appearing after discharge, and also occupational infections among the staff of the facilities. So it affects both the developed and developing countries. It doesn't spare neither of all the neither part of the world. Over 1.4 million people affected, and its incidence are quite high. As per India, is 19.6% as per ICMR guideline, ICMR reviews. Most common infection is the surgical site infections, constitute about around 57.2%. And second is the urinary tract infections, and third is bloodstream infections. Come down to the lower respiratory tract infections is a pneumonia. So most of the patients are subjected to any form of interventions when they admitted to the patient to the hospitals, be it the surgical procedures, be it intravenous therapy, intubation at the operation theater or ICU, or catheterization in the general ward, trauma center, or be it in the ICUs. So our patients are subjected and exposed to the hospital-acquired infections at the same time to the healthcare worker. So this has laid a burden to the patients and make more compromise and make more and more hospital-acquired infections, and led to the ward and inter-hospital transfers, again increasing the hospital-acquired infections from the previous hospital to the next hospitals, and increasing the antibiotic resistance. So this has increased the workload to the staff as well as the resource consumptions. So hospital-acquired infection is inevitable, but we can prevent it by adopting certain postulated cares. So how it happen, like, is a complex interactions between the patients, to the hospital environment, and to the healthcare workers. So the patients are subjected to multiple environments, which has led to the development of infections, starting from the air, water, and food he consumes or she consumes, and the patient's normal flora becoming to the pathogens, and a formite and devices and drainage which are subjected while in the hospitals, and from the other patients and the visitors, and to the hospitals itself. So most of the hospital-acquired infection is a major pathogen is a Staphylococcus aureus, among mostly is a Bacillus MRSA. Second is Enterobacterial C, and third is the Pseudomonas strains. So how hurt hit it to the patients and to the hospital resource and to the hospital administration is that a patients without the hospital healthcare associated infections has an average time of stay is 4.4 days, whereas in the rest of the patients with the multiple like the varieties of hospital-acquired infections, their length of stay is increasing considerably and very significantly. This has given a lot of hardship to the patients and to the administrators. So to cite it a very common procedures which we often overlook, where lies the and where is the portal for the contaminations leading to the hospital acquired. Started to the skin and the catheter interfaces, where is a Y connector where we used to add the drugs. Another is a tube and bottles interfaces, and lastly is a corking of bottles just to allow the free drainage of fluids. And sometimes in the crack, and sometimes the material, the IV sets are IV drips are prepared of, say, be lactase or be the DICP or be the PVCs. And second is a very common, again, another common procedures which has led to the hospital-acquired infections, mostly to the urinary tract infections. There is a junction of the catheter and the meatus, and the catheter and the tubing to the bag. These two are very usually overlooked, and this has led, and the price has to be paid by the patients and to the healthcare administrators. So this study, this Professor Alan Lex has conducted a study on the drug delivery system's role in preventing the central line associated bacteremia, and they found that not only the educations from have play a role to the preventing the bloodstream infections, but the technology and the scientific backgrounds have a role in improving the drug delivery systems. And so they make even 7 recommendations. So this scientific way, I mean, an innovative way of preventing the hospital-acquired infection is that in terms of making a very scientific and scientifically proven materials which are made up of these infusion systems. So the recommendations are that the phase strategy for bloodstream infection reductions, integrated risk management, selecting drug delivery systems, and separate team for infection control, and sufficient evidence of infusion safety of closed over open containers, and empirically determine the risks from microscopic contaminations. So there is a how is the difference between the open system and the closed systems. We every day, every now and then have encountered this PVC made of IV bottles, and now recently come of the freshness curvy like free flex. So what is open system? They are made of either glass bottles or semi-rigid or plastic containers, which are non-collapsible with, and does not have a separate infusion port. So they need a poke, they need a needle poke just to drain completely. And at the this led to the contaminant to get inside the fluid and get again to the human to the bloodstream and led to the infections. Whereas in the closed systems, these are collapsibles, and these have an inbuilt separate inbuilt injecting and injecting port, and does not need any probe just to make it free flow. And the residual volume is also very less, minimal. That a nominal 5% does not exceed 5% of the nominal volumes. So the need of the closed system is a paramount at this era of hospital-acquired infections. So the multi-centered prospect study in Italian ICUs has found that the cumulative probability of bloodstream infection was quite low, that is less than 5% among the closed container, whereas in the open container is 42%. So the graph depicted, it was quite low in the closed systems. And another like meta-analysis done by Dennis G. Mackey with a total number of patients like 4,373 patients. They have noted that a quite significant reduction in the hospital-acquired infections, leading to decreased ICU mortalities. So the countries like Argentina, Mexico, Brazil, and Italy. So the same is done in the India, like under the Director General Health and Family Welfare under the National Center for Disease Control. They adopted hospital infection prevention and control guidelines and led to the establishment of infection control committees. These are exist in most of the hospitals and healthcare centers. So they are the integral component of patient safety programs, and they are responsible for establishing and maintaining the infection prevention and control and monitoring, surveillance, reporting, research, and educations. So they advocated maintaining the abscesses, and by employing, by adopting of physical methods, boiling pasteurizations and UV radiations, etc., and a chemical agent using like alcohol, like the 70%, or aldehyde base, halogens, phenol, surfactants, and heavy metal dye and oxidants. So categorizing certain guidelines on certain instruments based on the invasiveness with the instrument to the human skin or mucous membrane, they classified as a critical instruments or no semi-critical instrument, non-critical instrument. Like critical instrument where there is a penetration of the intact skin in the mucous membrane, so they need a sterilizations before and after use like surgical instrument. Whereas a semi-critical instrument and non-critical instrument where the invasion is very less, so they require a low level of disinfections. These are given well in the ICMR infection controls reviews. So the role of the physicians also is also played in major roles while preventing the hospital-acquired infections by adopting or by appropriate practice of hygiene, say hand washings, isolations, and by protecting their own patients from other infected patients and from the hospital staff who may get infected. So by complying with the hospital practice approved by the infection control committees and obtaining the appropriate microbiological specimens with an infection when an infection is present or suspected. So notifying cases of hospital-acquired infections just for the surveillance, research, and leading to the educations and implementations. So the universal and standard precautions for hospital-acquired infection is they are very simple but well proven methods like hand hygiene, personal protective equipment, self-handling and disposal of surf and needle stick injury protocols, self-handling of disposals, blood and body fluids, disinfection of equipment and environment, and immunizations and isolations. So hand hygiene is a well-established fact. We should be follow all these 8 steps. We should not miss in any step, and putting in mind the finger crevices in between the fingers. So we need to follow strictly. Though it may overlook, we may overlook, but let's keep in mind that this 8 step before touching any patients, before undergoing any procedures. So WHO 2009 has pointed out a 5 moment when we need a hand washing. Start before touching a patient. Second, before undergoing or before attempting for any procedures. And third, after touching or exposure to the body fluid. Fourth, after patient contact. Finally, after the contact with the patient's surroundings. And lastly, personal protective equipments. We have these component like the gloves. It may be double slide, triple slide, or a gown, waterproof gown, or a mask, and the goggles. At present, the COVID-19 era have increases another some components of like in terms of eye face shields or in terms of shoe shields, shoe covers. Here is a self-handling of sub-instrument. We must keep in mind that they are the source of hepatitis C, V, and D infections and HIV. So we must ensure that we should not pass while handling the sub-instrument from one hand to another, self-handling of broken and disposal at a specific point of time and a place. And we should not let fill up more than two-thirds of the containers. So we should be aware of inoculation injury policy for a particular local hospitals. So during our MBBS times, we have taught, and now let's recapitulate how the starting from the generations of solid biomedical waste collection, storage, transport, and in a specific color-coded bag. There's black, red, yellow, blue, and white, and their appropriate and specific disposals. So, because of my time constraints, I'll not go in details about the type of the biomedical waste and disposals, but I just like to highlight the importance of biomedical waste management. So, in summarizing, infection control checklist. Do you wash your hand? Use the personal protective equipment and preventing the self-injury and self-disposal of waste material and spillage and thoroughly decontaminate equipment, maintaining the clean environment and to know at the time of accidents, and we must know our workplace procedures. So I'll take the advantage of sharing some innovative products which is manufactured and marketed by the Freshness Kavi in terms of fresh relax. It is made up of neither latex, PVC, or it is made from polyolefins, where there is no effect on the drugs or on the fluids, neither absorption, neither toxic reactions. They have a self-sealing, so they can be separate infusion and injecting ports. So the ports are hold the infusion cells very tightly. So I have been using once the product has been into available in the market. So there is no risk need of re-sterilizations for a high-risk OT. The bag has been packed inside a primary with a primary bag which is already sterilized in a controlled temperature 121 degree, and so the pores are self-sealing. No point of decontamination, no point of air contamination or leakage, and no need to poke by the needles. So free flex there is very safe. There is no possibility of microbiological, particulate, chemical contaminations, and no medical error because the bag is transparent. We can see through and through, and there is no point of drug incompatibilities, and because the raw materials and to manufacture the bag is different from the other PVCs. So, and no chance of ear embolisms and no self-injury because no need to puncture or no need to poke the bottles. So to conclude, let's make a clean care for the safer care, and thank you.
Thank you so much, Dr. Rakesh from Imphal. Very nice presentation, and you have presented hospital-acquired infection and method of its prevention very nicely. So thank you very much.
Thank you.
I request all the speakers come in the room.
Acquired infections. The chances of contamination in an open system are 10 times higher than closed system, like the collapsible bag. Closed infusion system is superior to open system in providing prevention against hospital-acquired infections. Hence, it is now time to break this chain of hospital-acquired infections. Introducing the new innovation from the leaders in volume therapy worldwide. FreeFlex DEHP-free, non-PVC environment-friendly solution to infusion therapy. Sterilized at 121 degrees centigrade within secondary wrap, hence no re-sterilization required. It ensures maximum asepsis of the primary bag. FreeFlex bag is made of polyolefin and is water vapor resistant, so no adsorption of drugs on the inner surface of the bag. FreeFlex bag is self-collapsible bag and therefore does not require any air vent. FreeFlex bag has innovative infusion and injection ports, especially designed for safe and easy handling. It has rigid sterile injection and infusion ports. Therefore, force required to pierce is adequate, hence prevents needle stick injury. The ports are sterile and have tamper-evident break-off caps with color and arrow indications. Membrane below cover is aseptic, disinfection of the membrane is not necessary. The ports are self-sealing to prevent leakage even after multiple spiking. FreeFlex has an excellent drug compatibility with over 40 commonly used IV drugs. Fresenius Kabi has TGA, WHO, FDA Taiwan, and NDA Uganda approved plants, which export to Australia. From the makers of Innovative Infusion System Solutions, we offer you a range of fully closed system bags. FreeFlex Standard Solution, Kabi Light FreeFlex, Valu Light, Kabi Mall, Valuven, and Kabi Solid. Together, we can create an infection-free world with FreeFlex, a state-of-the-art, award-winning innovative patented bag like none other across the market.
Okay. I would like to call Dr. Ajit Kumar. Ajit Kumar. Ajit Kumar is here? No.
I think he's not there, sir.
Okay. So, you have any question? Huh? Hello? So I
Yeah,
request all the speaker. Okay, Doctor.
With your permission, sir, can I ask a question to Dr. Saikat?
Okay.
Sir, there was you told about the intubation box. We have been using it for last 2-3 months, but recently there was a article which came that the intubation box causes more harm than benefit. So, what's your comment on that?
I think I kind of mentioned this right at the beginning. So, there has been this issues with the intubation box. There are pros and cons. I don't think you have heard the last from it. The issue again is whether you're using intubation box or you're using a plastic transparent sheet or a plastic cover. You need to be aware that the inside of the intubation box will have the aerosols which will be hitting the walls, right? And so when you're taking it away and when you're dismantling it, before you dismantle it, you need to ensure that you are actually cleaning that surface properly, taking adequate precautions. So as I said, I think before you start doing anything, the simulation training has to happen. So your operating room technician has to be aware as to that the potential that it has of contamination to the person who is handling it. The other issue that the people who have been saying against the intubation box has been that the intubation, when you use the aerosol box, the virus which is loaded in those aerosols are being trapped inside that. And when you are removing it, then the sudden gush of thing can happen. People who have used it from the beginning, including us, when you're using the aerosol box, you could have seen, I could have shown it again, maybe at some point of time. It is essential that you put in a suction apparatus inside the aerosol box so that there is a constant suction that is happening of whatever is coming into that aerosol confinement box. But all said and done, it is just a measure to confine the aerosols. It is never going to be a fail-safe. There will be pros and cons. I keep repeating this again and again. The ultimate thing is how much is you and the other healthcare workers who there in the operating room are being protected from the spray. So that is again boils down to your mask, boils down to your eye protection, boils down to your face shields, and then what you're doing with your hands.
One more question, which I want that I should ask that everybody should benefit of it. Suppose right now we don't have much of guidelines available regarding, because this is a very new disease. Suppose you have got a patient who lands up in a hospital with a semi-urgent surgery, and on admission you saw that he's a COVID positive. So when it is safe to take that patient for because it's a semi-urgent surgery, you can always defer it. How early you can take that patient for the surgery?
Yeah, I think if I've understood you correctly, Ritesh, what you're trying to get to is somebody with who can wait for maybe maybe a week or a couple of weeks or maybe a month. And the classic thing that can happen to you is somebody with a trauma or a fracture who gets into the hospital, and as per I think most hospital protocols today, it would be that they would be tested for COVID-19 and RT-PCR is done. And we have faced this similar situation as you mentioned, that they turn out to be COVID positive.
Yeah.
Okay. The protocol that we follow is then if the person needs to be hospitalized and cannot go back home, that is the first call that you take. I think that is a surgical call along with the infectious disease or the COVID consultants that we kind of talk. It's a collective call. If they need to get into the hospital, they obviously go into our COVID wards. We have a segregated, thankfully, we have two separate buildings. So two buildings, one is the COVID building and the other is, this, we call it the clean building. So they get into the COVID ward and they're monitored in the COVID ward. Now comes the question is, when do you get them into the operating room, right? They need to come into the operating room. Yeah. The first thing that I think you need to rule out is, did the person have any features of COVID? If they had features of COVID, then it is more, I think it's clearer that the clinical signs and symptoms of COVID has to go away. And then you at least mandatorily wait for at least 10 days. Some people who are more conservative would say 14 to 17 days, right? And then take up for the surgery. Now, the next question comes, do you test again before you take it up? I don't think you have a very clear-cut policy or a guidelines. I tried to look up for this in the American surgical, what is it called? Their group and the SAGES group rather, and the group from UK. They have not got a very clear-cut mandate on this. What we usually do is, yes, we would do an RT-PCR again, maybe before the person comes in for the operating room. And if they are negative, I think your problem goes away and they come in for the operating room. Now, you do have a chance. There is always a possibility that they don't have any features. It has been more than 10 or 17 days since the last signs and symptoms of COVID were there. It has been more than 10 or 17 days since the first time they were tested as positive and they have remained without symptoms. And then again, they test as positive. Now, what do you do? I think this is a very difficult call. You won't get a clear-cut answer. I think it has to be a collective decision as to whether you can again wait and how long can you keep waiting, how many times do you repeat the RT-PCR till they become negative? Because if you look at what is coming out from the data from outside, yeah, people have no symptoms. People are not shedding virus, but there is that nucleic acid fragment that is there in the nasopharynx, and then they're being tested as positive. The issue then becomes is the person may not infect other people. The person may not be infecting, but then having a certain amount of a viral load or whatever in their system or not, and will that influence the perioperative outcomes? I don't think you have got a clear-cut verdict on that. Because it has to be individualized, and I think if you had something like an imaging before when they were got in and were RT-PCR, you possibly do an HRCT again, see whether there has been a resolution of that, then you kind of know that the disease is not progressing, and then possibly take it off. It has to be inform the relatives that there is a chance that
the dilemma is regarding the ICMR guidelines, and the guideline which I saw, because the SAGE guidelines which I saw, they tell that if this patient doesn't have symptoms for 72 hours and two simultaneously negative RT-PCR, then you can take up those patients for semi-urgent surgery. But the ICMR says that after 10 days, the patient is non-infective, and they are practically discharging from the COVID centers. So basically, that dilemma is creating a confusion. What to do?
Because
may I say one thing here?
Yeah, Pratisa, please.
Yes, sir, please, sir.
Actually, the ICMR guidelines are looking at what is the load on the country and the economy and how much they can tackle it. It's not always going exact science. It is a demand and supply and problem-based answer.
Sir, I agree to it.
Ritesh and Pratisa, see the guidelines, the ICMR one, they have not handled this specific thing that we are talking about taking this patient for surgery. It is mainly for discharge from a facility or discharge from home isolation or those isolation centers. As you said rightly, if say the SAGES one is very particular. If you want to take them up early, say they are free of symptoms, they were in the hospital, they are free of symptoms, 3 days or 3 days free of symptoms from the last fever without antipyretics. You do an RT-PCR, it is negative. Do another RT-PCR negative, take them up for surgery. That's a quick way of channeling them.
The standard precautions will have to continue. We live in the patient is COVID positive and we are taking up early, so we follow precautions and continue with the case.
The issue then is whether it is that I think that I think the Wuhan and the Spanish study about major surgeries. I don't think they have talked about intermediate kind of grade surgeries. Major surgeries that you have this 20% extra risk of a perioperative morbidity mortality happening if they still are harboring the virus.
Right.
Unknowingly. That's the issue. Yeah.
Right, sir.
Yeah. Manoj, if you
one
can
question
scan
from Rajiv.
if you can scan the question.
One from Rajiv. How to correlate pulse oximeter wave and fluid status in a spontaneous ventilated patient? So I think fluid management by Pritik Bhattacharya sir. Sir, question for you.
See, since the time pulse oximeter came when I was in BHU, in those early days when there was a standalone pulse oximeter, we used to notice that whenever the patient is hypovolemic and on IPPV, the venous return and the cardiac output, when the stroke volume used to change and the height used to change. What has only changed over the years is that the people with the equipment, they did the maths and did the area under the curve, and they came out with a formula and gave us a percentage. But the basic rationale was that whenever there is a hypovolemia and that is exaggerated with intermittent positive pressure ventilation or any amount of positive pressure coming into it, and that affects the stroke volume each time. So we know there is hypovolemia. And these are very easily found when the patient is, especially on IPPV, very easily detected. And you see gross changes. But when a patient is spontaneously breathing, we have to have a higher index of suspicion and acceptability that because this patient is not having IPPV, he is having a negative inspiratory force. So, but any changes that occur, if it is even slightly more than normal, you see, we see equal size waveforms in the patients who are normovolemic. So if there are changes, even say a 20% change in the height pattern in a spontaneously breathing patient, we will suspect the patient is hypovolemic, provided the patient is not having a known cardiac failure at that point of time.
Okay.
And
it is a poor man's measure.
No arrhythmias as well.
Yeah, yes, it is a poor man's measure, just like we say urine output is the poor man's measure of a cardiac output.
Okay, sir. Another question for you, Pritik sir. Role of balanced crystallized solution like plasmolide, is it better option in comparison of NS or RL?
Okay, here I'll say one word. Jitna shakkar dalo, utna meetha hoga. Now, if the patient can afford the rest of the treatment modalities without affecting his financial crisis on the rest of the treatment, then this is fine. Otherwise, the risk-benefit, cost-benefit ratio is not much.
One question for Gautam.
Our patients come, they can't afford the antibiotics, so I will give a perfect fluid and compromise on the antibiotic. These are the problems we face every day. So if it is not a major issue, and 99% of the time, it is not a major issue, my apologies to Fresenius Kavi.
Okay, thank you, sir. What is my question to Sekat Sen? What is aerosol box? And sir, what is aerosol box?
I think aerosol box, I showed it in the, I had to rush through the slides. The aerosol box is nothing but, I think it's a polycarbonate kind of a thing, which is transparent. And it is covered on 1, 2, 3, and the upper surface, so fourth surface. There is one surface, one side which is open through, basically through which the patient's torso goes in. and the lower surface is obviously open and it rests on the patient's table. So if this the patient is here and the aerosol box is covering this, and you have openings through which you can put in your hand. The trick of using the aerosol box is that once you start, before the box goes in, the circuit has to come in through one port. Ensure that a suction machine or a suction apparatus is inside the aerosol box, and the open end is finally covered with a plastic transparent sheet as well, so that then it is kind of covering it up. Ensure that the whatever your airway equipments are inside the box, and you are then holding the breathing circuit with the mask on the top of the patient's face, and the patient starts breathing. And with the aerosol box, the few things I think that is what I said, that there is a huge role of simulation and training, because when you're going to use the aerosol box, remember there will be 3 refractions that you're wearing. If you have glasses, this one, then you have got your goggles. If you have got a goggles, you have got a face shield, and then you have the first called polycarbonate layer on that. So there is going to be refraction problems, and you have to be aware of that. I have found that if I'm using the aerosol box, I find it easy if I'm using a video laryngoscope. And if I'm using a video laryngoscope, especially with a monitor that is outside, not mounted on the laryngoscope, it is a much easier proposition. So I can then look outside and then pass in a tube. So that is what the aerosol box is. If the person can just email me, I can send him the video of aerosol box. We have a few of them already, or it is already put up in the HCP Edupo forum also, if you can look into it. Then the question comes is when do you remove it? What I follow is I at least give it a time, and for some time. By this time, you have put in the tube, you have seen your ETCO2 curve, you are happy with the airway pressures, and you know that you remember you will not be able to auscultate bilaterally to figure out bilateral air entry. So all these things that happen. The tape to fix the endotracheal tube is also inside. So you do all that, and that takes around 4 to 5 minutes of time, and it settles down, and the suction has been working. The person who's going to remove the aerosol box, you have to be very, very careful. So that aerosol box is lifted out. Somebody is not touching the inside of the aerosol box, and then goes to our washing area, and then it is cleaned off. And it during extubation. Yeah.
Sir.
One surgeon is putting in the suction tube inside the box for it, so that the whatever is the droplet that is going around inside may be taken out maximally, and the surface contamination will be left.
Yeah. But then again, there are people who have spoken against it, and it's a point well taken. You need to be careful about it.
Sir, my question to again Dr. Saikat Sen. If our RT-PCR report is awaited, then rapid test is only positive, then how can we manage the emergencies case? Yeah, wait for RT-PCR.
I think I follow a simple dictum in the operating room, is that to me, even if you come with an RT-PCR negative report, I would think that there is this person is still harboring it. There's a 30% chance he's still harboring. So I do not put my guard down about my PPE and my colleagues, my students, my staff, nurses, technicians. But the only thing is, for me, the PPE does not mean the Wuhan spacesuit. I don't believe that is, and that has made people very scary about PPEs. You don't need to have that kind of a spacesuit. You have a proper fitting, no leak mask, possibly a surgical mask on top of it, if you want to be more careful. A mask, I do not like masks with valves. I think it is possibly not a very ethical thing to do. Then you have your visor shield, and what I would do is if it is very highly suspicious, then I definitely wear those, as I showed those pictures of those impermeable gowns, and then do whatever the procedure is being done. If you think that impermeable gown is going to be an issue with cost, have the surgical gown on, and then maybe wear something like a wear-on, like a transparent plastic sheet on top of it. And whatever you wear, you also need to be very, very careful how you remove it. So don't wear something which is very cumbersome. I get scared when the people wear those hoods and everything, because removing those hoods can contaminate these areas. So, and the other thing that we follow, and I think it's a good thing to follow, because if you are, once you have done a absolutely proven positive, I tell everybody, go and have a shower before you come in. So after you have done the doffing well, you've done the doffing well, and the only thing is, do not remove your mask before you go to the area where you can wash your face. So, because it's no point, if you think that particular environment is still harboring the virus, do not try to change your mask over there. That is, some people differ with me on this, but I kind of prefer that you do not remove the mask. Go to the shower area or go to the basin, and then we have a place where you can remove the mask over there and then have a shower. Do it.
Okay, thank you very much, sir. One question for Dr. Gautam Shah, who is not actually in our room. How much paracetamol can we?
Manoj, finish the questions for the three of us, and then bring them in, and then get the questions for them.
Yeah.
We will
If
go
I
out.
am finished, I can leave.
Yeah.
One question, sir, just from senior member of ISA Patna, Ashok Gupta. How much paracetamol can we give, which will be not harm for the patient? How much paracetamol do, which is not harmful for the patient? Anybody?
See, the upper doses are always in a critical care scenario. The liver reserves are always down. So if we have already been protecting the patient with thiamine, then we have got some scope. So usually we don't go for more than 4 doses in a day. But if the patient's the liver reserves are down and we have not taken the precaution on the second day with getting the thiamine, so in that case, the patient may have some problem, otherwise potential problems. But it's in a ICU scenario, the dose range will vary.
Okay. Thank you very much, sir. Thank you, our sponsor, Francis Kabi, for sponsoring such a nice virtual first, I say, virtual webinar. And thank you, HCC, for conducting the station and conducting the first virtual webinar of the ISA East Zone. And I request Dr. Sekhar Sen Gupta for vote of thanks.
No, I think before I say the vote of thanks, I think, Alam, if you have anything to say, few words from you before we wind up.
No, Doctor, I just wanted to thank all the eminent speakers for the knowledgeable presentations which they have given. And special thanks to Dr. Pitesh Bhattacharya, Dr. Sekhar Sen Gupta, Dr. Gautam Shah, Dr. Ritesh Roy, Dr. Ajit Kumar, and Dr. Rakesh Nangotham, who has given a very beautiful talk. And of course, Dr. Manoj Kumar for moderating this long webinar, but it was very, very effective. And also, finally, I would like to thank our participants who are also from our neighboring countries like Nepal and Sri Lanka. So, thank you, Doctor.
Thank you.
Thank you very much.
Them, so they are also there.
Thank you, Pritik sir. Thank you, Ritesh.
Thank you, sir. Thank you, sir.
Okay, sir.
Thank you. Thank you, Manoj. Well done. Thank you.
Thank you.
I request Sekhar Sen sir.
Okay, thank you very much. I think I'll take this pleasure and privilege to wind up. Before that, I think first and foremost, our parent organization, Indian Society of Anesthesiologists, the headquarter. I think a huge thank for Dr. Naveen Malhotra, Dr. Murlidhar for joining in and giving us words of encouragement. Manoj, thank you very much. You are the person, as I said, with a huge amount of energy. I don't know, तुम क्या करते हो पानी के साथ जितना इतना तुम्हारे में इतना जोश. So for sitting through this entire thing, and needless to say, Fresenius, thank you very much for being a part of this and bringing it all together. I also need to thank the HCP forum for managing the back end. I know we had any initial glitches, but I think they managed it well at the end. And because it takes a lot of trouble to get in people, especially when you have so many speakers and then a moderator and people coming in and going out. I think that everybody is supposed who have attended this webinar is also supposed to get a certificate from the Indian Society of Anaesthesiologists. So I think we need to find out from Dr. Jayati as to how they get it before we wind up. So I will leave it to her, and she will tell the people who have attended how, or they'll get supposed to get a thing. And Pitizda, Dhonnobad, thank you. Onek din gola melano hoyni. So we will meet soon. And I'm looking forward to the hills and your lovely ambience and your hospitality. It's been a long time that I've been there, so I need to be there very
Welcome to all of you.
Yeah.
Welcome to all of you.
Thank
Yeah,
you.
Ritesh, I think this was the weekend for the punch, isn't
Yes,
it?
yes, it was a weekend.
Yeah,
for the
I was looking at my calendar and I figured out this was the weekend for that.
Yes.
Anyway, we will do it.
Yes.
We will
We
keep
will.
having this.
Yes.
Until we have this, let's live on with this. And
Exactly.
thank you, everybody. Well, I don't know. It would have been lovely to have Ajit, Rakesh, and Gautam Da also with us. Thank you very much, Gautam Da. Thank you, Ritesh, Rakesh, and Dr. Ajit for being over here. And
Thank you, sir.
as you said, we will possibly take this forward. Manoj, we'll take
Sure, sir.
ISA East Zone meeting or a combined meeting of ISA East Zone and Northeast, and
Yeah.
on the web.
You are our editor in chief. So as said by Dr. Naveen
Please ask people to send in the articles. We possibly, I think I will talk with Dr. Naveen and we'll figure out how we are going to do it. Yeah.
This is
Thank you very much.
Okay.
Dr. Jayati, do you have anything to say about how people will get their certificate?
Yes, sir. I would like to thank all the faculties. I would like to thank Fresenius Kabi for arranging such a wonderful program. I would like to thank ISA for taking the initiative to bring in so many delegates. So everyone who has participated will be receiving a link on their registered email ID to share their feedback. So once they share their feedback, they will be receiving an e-certificate signed by the office bearers of ISA. And 24 hours after the live session, you will get a link on your mail to view the recorded version of the session in the online platform of HCP Forum. So the online platform edu.hcpforum.com has been sticked over here. You can go through and you will receive a mail from where you can just log into the online platform and you can see the whole recorded version and other recorded versions also on various topics in the forum. So thank you, everyone. Thank you, all the
Thank you.
faculty. Thank you.
Bye-bye.
Do we sign off right now?
Yeah.
We'll.
Bye-bye.
Thank you.
Good night.
Good night.
Bye-bye.